Assalamu alaikum, everyone. I hope you guys are all doing well, inshallah. For those of you who don't know me, my name is Mohammed Alfuwais. I'm a fourth-year medical student, and inshallah, today I'll be giving you the third OSPE review of this year so far. This one's for MSI. Inshallah, today's exam went well for EBM. I heard decent things so far. Alhamdulillah, inshallah, it went well. Now for the next exam. This review, I'll be going over a lot of stuff. I'll be going over all of MSI pretty much, explaining everything and testing you guys on what you know and filling in any gaps that's needed for you guys, inshallah. And I'll be covering everything besides pharma. Okay, so this will be all of pathology, all of micro, all of clinical stuff, but only stuff that's going to come in OSPE, plus tips and other stuff as well. So here we go. And again, this session is interactive. I'll be asking you guys questions and you tell me the answer. Okay, so I need you guys to be interactive and ask questions if you guys want. So let's start right away. Can someone tell me what this disease is?
It's osteoporosis.
Good. Perfect. Okay, so what you see here on the vertebra is multiple pores. Okay, that's what it's called, osteoporosis. Now, osteoporosis is because of low density that happens in the bone because of numerous reasons. Typically, the age that presents is a postmenopausal woman. Okay, that's a typical age, typical case scenario that comes. What you see on histology or histopathology is thin trabecula and thin septum. And all of this area is just fat. Okay, that's what's causing the pores. Now, to ask you guys, how do we diagnose osteoporosis? What's the diagnostic tool that we use?
DEXA.
Yes. Okay, so DEXA scan. So we use DEXA scan to diagnose osteoporosis, and that's typically the diagnostic tool that we use. Okay, and there's a specific score to it. I don't know if you guys need to know it, but it's negative 2.5. Okay, that's the cutoff that we use. Okay, good job. Now moving on. Can someone tell me what this is?
Osteolytis fibrosis or fibrosis.
Good. Osteitis fibrosa cystica. Okay, so another name for this is brown tumor. Now, what's the underlying disease causing this?
Parathyroidism.
Good. Perfect. Hyperparathyroidism. Now, it doesn't matter what type. Typically, it's either primary, secondary hyperparathyroidism due to whatever cause that's causing primary or secondary. Primary is due to parathyroid lesions. Secondary is due to chronic kidney disease. And it causes high amounts of PTH. Now, what will this PTH do is it will activate osteoblasts that will then activate osteoclasts. That's how the mechanism works through rank L and rank receptors. Now, when osteoclasts are activated, it will start breaking down bone. So what do you expect to see in histology are osteoclasts, okay? What are these cells over here? Osteoclasts, okay? These cells are osteoclasts, and that's what's causing it to break down. Why is it called brown tumor? It's because of blood, okay? So all of this area over here will be filled with RBCs and all these other stuff. That's why we call it a brown tumor, okay? Crucial for you guys to know is this picture right here. Very important thing to remember, okay? You need to remember this histology picture very, very well, okay? Obviously here you can see multinucleated giant cells, which is osteoclasts, okay? Here you have multiple lesions on the fingers, and this is also just part of the osteitis fibrosis cystica in the fingers, okay? Moving on. Can someone tell me what this is?
Osteonecrosis.
Good, osteonecrosis. Now, osteonecrosis, there's multiple types from your slides, okay? There's the subchondral, which is what this one is, and there's something called medullary, which is more deeper inside the bone, okay? That's why the medulla is inside. Now, osteonecrosis happens due to multiple reasons. Can someone tell me the most important underlying cause of this?
A fracture.
Fracture is one cause. What's the most common one?
Steroids.
Steroids. Guys, remember steroids. Okay, very important to remember corticosteroids as a cause of osteonecrosis. You mentioned another cause, which is fracture. Now, the third cause is a hematologic disease. Could someone guess?
Sickle cell.
Sickle cell anemia. Perfect. Okay. These three are the most important. Vascular interruption can happen due to fracture, as you mentioned. Now, the areas that are commonly affected are two most common areas. Can someone tell me the two areas that are very, very affected by osteonecrosis or prone to happen? One of them is in the picture. It's what this is. And the other one is in the hand. Femoral head, good. And one more is the scaphoid. Perfect. Okay. These two areas are the most common areas for osteonecrosis. Why is that? Because of compromised blood supply. The femoral head and the scaphoid have weak blood supply compared to all other bones. Okay, the scaphoid has a retrograde blood supply, and only a portion of it is getting supply from one vessel. That vessel's gone, the whole bone is necrosed. Femoral head, same exact thing. Okay, it's getting its blood supply from one artery, which is a middle circumflex femoral artery, and that's it. Okay, you don't need to know these arteries. I don't think so. However, just to explain to you, that's why these areas are prone to osteonecrosis. So, next disease. Osteoarthritis. Perfect. Good. Now, before I get into the specifics of this picture specifically, I wanted to ask you guys, osteoarthritis typically affects which age group? Very elderly, like 60s, or middle-aged? Good. Very elderly. Okay, the elderly age group. Why is that so? It's because this is a wear and tear disease. Okay, it's a disease affecting elderly because of use. Okay, now, does this disease worse in the morning or in the nighttime? Nighttime. Good. Just a rule of thumb for you guys is autoimmune diseases or autoimmune causes of arthritis will have morning stiffness. Okay, it's worse in the morning and it gets better with use. The reason why is because at night the joints are rested. Okay, it's not moving. So when it's not moving, you have inflammation accumulating at the site. Okay, and then in the morning it's going to be very stiff, so you start to move it around and this will move around the synovial fluid. Okay, so this improves symptoms in autoimmune causes of arthritis. Now, are there systemic manifestations with osteoarthritis? No. Perfect. Good. Are there any specific antibodies we use to diagnose osteoarthritis? No. Perfect. Now, can someone tell me which joints does it affect in the hands? Does it affect the distal interphalangeal joint? Yes, perfect. It affects the distal interphalangeal joint and the proximal interphalangeal joint. Perfect. I'll answer this question later, inshallah. Okay, but don't worry. Okay. So in this picture, can someone tell me what are these nodules called in the distal?
Dents.
Can you say that again?
Heber dents.
Good. And then the one that's affecting the proximal joint?
Bouchard's.
Perfect. Okay, the way I remember it is BP. Like they sound the same. So Bouchard, proximal. Okay. And then the rest is Heberden. Okay. So that's that. The joints now, is it symmetrical or asymmetrical?
Symmetrical.
It's asymmetrical. In osteoarthritis, it's a wear and tear thing. okay? It's mostly affecting weight-bearing joints, okay? So you might have in this picture, it looks symmetrical, okay? It feels symmetrical. However, it's not. So you might have one knee that's affected more than the other. However, in autoimmune, you'll see that the both sides are the same. Both sides are affected. If it's affecting both hands, it'll affect both hands. If it's affecting both knees, it'll affect both knees. Okay, so that's that. Usually we diagnose this clinically. However, we do need to do imaging. And this is very important, guys. This imaging, next slide, very important. Can someone tell me this disease, firstly? Osteoarthritis. I want you guys, let's go one by one to tell me all the signs. I'll answer your question, Leanne, in a second. What is this sign?
Osteosclerosis.
Osteosclerosis, okay. Is the joint space affected?
Yeah, it's narrow.
Good. What are these? Osteophytes, good. Now, what's this one in this image? Because it's more clear in this image.
Subchondral
Not
cysts.
abscess, cyst, okay, subchondral cyst, okay, perfect. These four, very important, okay? It's gonna either come in your MCQ, in your SAQ, or in your OSPE. Know these four findings by heart, okay? And the best mnemonic, as mentioned, is SONS, okay? SONS, okay? Now, the joint space, as someone already mentioned in chat, is not fused, okay? It's narrowed, but it's not fused, which is very important for another cause of arthritis. Now, whether or not you need to know what's polyarticular and oligoarticular and stuff like that, you do need to know something very important, which is if it's monoarticular with signs of fever and stuff like that, you're suspecting one type of disease, one specific, very important type of disease. If it's polyarticular, most of these types of arthritis is polyarticular, okay? There are some that's oligoarticular, but you just need to know the definition of what is mono, what is oligo, what is poly, okay? So if I ask you, which is monoarticular, is how many joints affected? One. Oligo? It's mostly a range, not just a specific number. It's around 2 to 4 joints. More than that is poly, okay? So that's the cutoff. Know what's in your clinical slide, I think by Dr. Fahad, he probably gave it to you guys. Know that definition very well because it might come in MCQ. OSPE, it probably won't come. Tamam, this is osteoarthritis. Wear and tear disease. So if you do, for example, a joint aspiration, it won't be inflammatory, okay? So that's a key important thing that you remember from this disease. Now, one subtype of osteoarthritis is something called erosive osteoarthritis. There's not much you need to know about what this disease is and what type it is and what not. Useless information. What I need you guys to know is just memorize this sign because it might come in your OSPE for radiology. So here, for example, you have a seagull appearance. This is a sign of erosive osteoarthritis. If you need to know all the features of the disease, not really. You just need to know the important bits that can differentiate from other diseases. So for example, for osteoarthritis, I mentioned it's asymmetrical, it affects the distal interphalangeal joint, it's non-systemic, it's non-inflammatory. Okay, so that's important to differentiate it. Imaging-wise, it's a kind of important to remember. Okay, and specifically for osteoarthritis, the 4 signs are very important. Moving on. Can someone tell me what this is?
It's a Charcot's joint.
Perfect, good. Now, Charcot's joint, I don't think will come in a lot of forms in this exam. And it's not as important. However, it's just important to know why is it caused. So Charcot's joint is basically when someone does not feel what's it called? Their joint, okay? They have poor proprioception. They keep walking into things and they keep getting their knees damaged. And over time, it causes this Charcot's joint. So by that definition of what I mentioned, and no affects proprioception, give me 2 neuro diseases that can cause this. I gave this lecture last year for PAL. Okay, peripheral neuropathy. Good. It's caused by diabetes. Tabies dorsalis, and one more. SCD, okay? And you have some chemo drugs such as methotrexate, which can cause neuropathy, and some other stuff as well that can cause neuropathy and demyelination and whatnot that can cause this, okay? More importantly, in neural basis, is the dorsal column proprioception. It's important for diabetes. Very important. Diabetics can develop this because of poor proprioception due to neuropathy. Don't worry, you can ask as many questions. For those specific questions that you ask, I will answer them later on, okay? Now, can someone tell me what this diagnosis is? Rheumatoid arthritis, perfect. Now, rheumatoid arthritis, it's an autoimmune disease. It can manifest with so many other diseases. It's systemic. Now, I want you guys to tell me the signs that you can see on this picture. What is this sign?
Swan neck.
Swan neck deformity. This one?
Boutonniere.
Boutonniere. And this one?
Radial deviation.
Someone already mentioned it. It's ulnar deviation. Okay. So here in this case, you can say, okay, if you look at this over here, the ulnar deviation is flexion of the distal interphalangeal joint with extension of the proximal, right? You might say, okay, is this affecting the DIP? No, it's affecting the tendons that's causing the flexion, okay? That's why it forms this swan neck deformity. Rheumatoid arthritis does not affect the DIP. Very important. Now, signs and symptoms, very important. Is it systemic? Can it cause systemic signs and manifestations? Yes. Okay, very important. So examples of this are, for example, very commonly in a lot of these autoimmune arthritis causes are, for example, uveitis, seen in a lot of them. You have, for example, pleuritis that can be seen. You have nephritis that can be seen. You have a lot of different stuff that can happen. Okay. Now, it's worsened in the morning, as I mentioned, and it gets better with use. Okay. It's most likely seen in what gender? Female. Rule of thumb, autoimmune diseases are typically seen in females. Okay. More prevalence in there. Now, can someone tell me, there's one that's coming up that I will ask you guys about. So can someone tell me what's the most specific and sensitive antibody for this? Good. Okay, anti-CCP. Can someone tell me one other antibody that you can find as positive in rheumatoid? Rheumatoid factor, perfect, good. These two antibodies, most important one, most sensitive, specific, CCP, okay? Anticyclic citrullinated peptide, okay? CCP. Rheumatoid factor is not as specific. It can be positive in other diseases as well. Now, for the joints, we already mentioned differentiate from osteoarthritis and rheumatoid arthritis. CRP, ESR are not antibodies. They are markers of inflammation, okay? So when you're suspecting osteo or rheumatoid arthritis or even SLE, for example, in a lot of these diseases, you have to do ESR CRP as your part of your lab investigations. The reason is because ESR CRP are acute phase reactants that gets released from the liver, okay? And if you remember from POD and immuno, acute phase reactants are increase in inflammation because of cytokines that goes and stimulates it. So CRP and ESR are these acute phase reactants, okay? And it's seen in inflammatory diseases. So that's, it's not antibodies. And we already mentioned the joints are affected. Now, one of the extra articular manifestations that we can see is this. What is this? You'll get 1 or 2 questions maybe from this, from the genetics lecture. Rheumatoid nodules, perfect. What is in this? What type of necrosis is seen over here?
Fibrinoid.
Fibrinoid necrosis, perfect, good. It's fibrinoid necrosis. Okay, remember rheumatoid arthritis, rheumatoid nodule. تمام. Can someone tell me what this is? Rheumatoid arthritis. Perfect. Good. Um, so for the person who mentioned one other answer, I'll explain the difference when I get to that specific disease. Don't worry. In this disease, osteoarthritis, in rheumatoid arthritis, is because you have inflammation causing by neutrophils, by inflammatory cells that's destroying the joint. The joint is going to start to react by forming something called a pannus. Okay. Slowly with time, this joint will fuse together. Okay. So here you'll have joint fusion. Okay. Very important. Pannus is something that happens with rheumatoid arthritis. It's basically reactive based on the inflammation. So because of the neutrophils that's damaging, it's going to start to form this pannus. I'm not too familiar with it. There's one slide in your pathology lecture that explains the pathophysiology or the pathogenesis of rheumatoid. Just summarize, like go through it very quickly. Okay. But the point of this is very inflammatory. Okay. So if you do aspiration, you will see inflammatory cells. You'll see a bunch of high amounts of lymphocytes. This one is from Dr. Urban's lecture, so don't worry. He explains it very well, the pathogenesis of rheumatoid, and it's very important, this and osteoarthritis. This image over here will show erosions. Okay. Someone already mentioned this, but I will ask again. What is seen in this image? The one all the way in the left. Subluxation of the cervical spine. Now, this is dangerous, and it's seen in rheumatoid because it can cause paralysis, okay? Just to keep in mind of this complication that can happen with rheumatoid. Tamam? The imaging, fusion of the joints, erosions. Okay, that's all you need to know for images. Okay? Okay, so this is cervical subluxation. Basically, the cervical spine, it's not stable anymore. So if you have someone who, let's just say an emergency case, needs to get intubated, okay? When you need to be intubated, you kind of have to do maneuvers to move the neck and move the head. So when you're doing this, if someone has subluxation, they can cause paralysis. It's not that they cannot move their head, but it's a risk factor. Okay, it causes paralysis because it injures the spinal cord. So it's not that you cannot intubate, it's more of once you intubate, a very important complication that can happen is paralysis because of this. Okay, you can still intubate, but you have a very important thing to handle. Now, can someone tell me what this is? Psoriatic arthritis. Perfect. Psoriasis. Now, for psoriasis, the derma part, I'll get to that later. Don't worry, and I'll have slides for this. But I want you guys to know the other signs of psoriasis. Now we're going into something that's called spondyloarthritis, or seronegative spondyloarthritis, or spondyloarthropathies. There's 4 of them. The 2 most important ones I included here. The 2 others I will just say briefly. But the 2, because of imaging, very important. Number 1 is psoriatic arthritis, and then another one is the next question. Now, in these cases, it's seronegative because if you do all the markers, the antibodies, everything, it's all negative, except one gene that's very important in these diseases. Okay, I'll not ask it here, I'll ask it next. So for psoriasis specifically, you'll see the signs of psoriasis, the skin lesions. Okay, so the salmon-colored plaques and all these things. Then they might have joints. The key sign here is a pencil in cup appearance. Okay, so it looks like this is, think of this as a pencil and this is as a cup. Okay, you're putting a pencil inside a cup. That's what the sign is. This is seen in psoriatic arthritis. Know this image very well. Okay, and then it can come in OSPE. Here you can see dactylitis. You can see sausage fingers, which is dactylitis. Okay, good. This is psoriatic arthritis. Now moving on, very important, this one. Can someone tell me what this disease is? Bamboo spine, ankylosing spondylitis. Perfect. Okay, ankylosing spondylitis. The key feature of it is bamboo spine. If you see someone at this x-ray of the spinal cord like this, ankylosing spondylitis. Okay, it's very important that you remember ankylosing spondylitis. The other sign is this. Can someone tell me what this sign is? Okay. With a lot of these seronegatives, you have something called sacroiliitis, okay, where it's basically inflammation of the sacroiliac joint. The sacroiliac joint, it should be a line that you can clearly tell over here like this. However, now it's very hazy and white. You can see part of the line over here showing, okay, like this line. Okay, but now it's not. You can't see it clearly. It's very hazy and white. The reason why is because in a lot of these diseases, this seronegative, you have sacroiliitis. One of the more common ones that features in is ankylosing spondylitis. Now, ankylosing spondylitis, what gender is it more common in? Males. This was the one that someone mentioned in chat. Okay, it's more common in males. The other thing is, what's the gene that's implicated in these seronegative and specifically, most commonly, this disease? HLA-B27. Guys, remember HLA-B27. Very important MCQs, and for OSPE, no bamboo spine. Okay, HLA-B27, ankylosing spondylitis, just get a male with back pain. Okay, that's a common feature of this. So, someone tell me, here in this case, it's just, you can see that in between the vertebral spine, it's starting to form the fusion. Okay. This, if you look at in bamboo, it looks exactly like this. You can see slightly here. It's not supposed to be like this. Okay. So, what's this disease, guys? Gout. Okay. So, can someone tell me what this is called? Podagra. Perfect. Good. So this is podagra. Podagra is basically the big toe. Usually you'll get a male around his 50s, 40s, but could be variable, who complains of very, 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 very severe pain in their toe or in their knee. Okay, common areas. It could affect other stuff. Over time, they will start to form something called tophi, which are seen in these images. Now, in these images, know this one, the one of the hand, very well. It's basically deposition of the monosodium urate crystals that's causing these changes in the joints. But you can see it's very damaged, right? Very, very damaged. Very damaged. Risk factors for this, important to note, is hyperuricemia. So they have, for example, if it's a child with gout, you think of what disease? If it's a child with gout. What disease, guys? if a child has hyperuricemia, not von Gurke. Leishmanian. Perfect. Okay. Leishmanian causes hyperuricemia and it causes these gout. Another cause is more commonly hyperuricemia due to, for example, diet, a lot of meat, alcohol can cause it, and so on and so forth. Okay. Management, you know the drugs you use, allopurinol, probenecid, pegloticase, so on, colchicine. Okay. Now, can someone tell me what this diagnosis is? And gout also is another thing, is it's usually presenting at one joint at a time. Like, for example, the big toe is very important. If you see a big toe case, think gout. Perfect. Okay. Pseudogout. Okay. So this is pseudogout. Pseudogout, I think in COM is very important for you guys to know. I'm not sure if they moved these lectures. Yes, to answer your question. But usually the most common location for these flare-ups are the big toe. Okay, very important location for gout. Okay, yeah, in COM, the difference between gout and pseudogout are very important. Okay, حتى in here, just know the imaging findings and the next slide. But here you have these lesions inside of the joint in between the bones. Okay, these are calcium pyrophosphate crystals. Okay, that's forming inside the joint. It's not causing destruction of the joint as much as you saw in gout as in this one. It's in between. Okay, these lines that you can see. Similarly over here and similarly over here. Okay. So these are this is pseudogout or CPP, something CPPD. Okay. So now, with all these cases, you have to take aspiration. Okay. Now, when you do aspiration, you want to see it. Tell me what this image is first. Gout. The other image. Pseudogout. Good. Now, when you're doing an immunofluorescence or you're checking for bifringence, if it's negatively bifringence, then gout. Now, what does this mean? Is you look at this needle-shaped crystal. That's another key term also, needle-shaped crystal. If it's yellow under parallel light, yellow, LL, yellow parallel, under, it's yellow under parallel light, this is gout. Okay, it's negatively bifringence. The other one is weakly positive. I'm not going into detail about what that means. Okay, but these are crystals. It's not a needle shape. Okay. I don't know if Dr. Urban included this in your slides. I could not find it personally. I don't know if it's some slide that I just missed. I keep missing, but I took this from your clinical slide. PBL. It's important to know these details. Okay. Tamam. Okay, so now you know pseudogout usually is in an more elderly patients. Bifringence is the color. Okay, that like brings. Okay. Usually more bifringence is blue, I believe. So if it's yellow, it's negatively bifringence. This specifically. Okay. Pseudogout, typically elderly, more older patient around their 60s, 70s. And then gout, you'll have underlying features, underlying risk factors for gout. Okay. Don't go into details of pseudogout as much. Now, if you have a patient who has very severe fever, signs of inflammation, one joint that looks like this, typically the knee, what are you thinking of? Septic arthritis. Perfect. Septic arthritis is monoarticular, one joint that's affected, and it's a very dangerous disease. Now, if you're expecting septic arthritis, give me one step in management that you do. Very important, both diagnostic and therapeutic. Aspiration. Good. Joint aspiration. You do aspiration, you're gonna need to culture, okay, the patient. Culture the joint aspiration. Now, typically you'll see septic. It's the joint is septic, meaning there's a lot of pus. There's neutrophils, okay? These are signs, and you see in the joint aspiration. There's a table in Dr. Aban's slide, very important table, okay? So that's these signs. Okay. Now, before we go into that slide, can someone tell me what's the most common organism overall that can cause this?
Staph aureus.
Staph aureus, good. If I have a patient who has sickle cell anemia, what's the most common organism? Staph aureus, okay? The most common organism that's causing it in sickle cell patients is Staph aureus. Salmonella is the second. This is for septic arthritis. For osteomyelitis, relax, the opposite, okay? Salmonella is number 1, Staph aureus is number 2, okay? This was something that was emphasized for us with micro last year. I'm not sure if Dr. Botta mentioned it this year, but it was emphasized last year. Okay, good. Know this. If I have someone who's in the reproductive ages, sexually active, what's one organism I can think of?
Gonorrhea.
Yes, good. Neisseria, gonorrhea. Perfect. Now, there's also another cause, which is if I have a kid who's not vaccinated, I might think of Haemophilus influenza as well. Okay, good. Can someone tell me what this organism is that's causing septic arthritis? Okay, and I can see why. Okay, it's not H influenza, it's the weird one, it's Kingella. Okay. Look, I brought this in here because sometimes they just bring very low yield stuff, and I wanted to make sure I cover this with you guys. It's Kingella. Okay. It's one of the only ones that actually had an image in the slides. So I put it, okay, to make sure that you guys know this. Kingella kingae. It's a gram-negative coccobacilli, and then what it looks like is in chains. Okay. So yeah, it's in chains. It's gram-negative coccobacilli. Now, it's more important in the pediatric age group. That's what I took from the sides, is that it's most important in pediatrics, okay, in children. That's it, okay? Let's move on from this organism. Okay, someone has this. What organism can cause septic arthritis in this patient? Staph epidermidis, coagulase negative staphylococci. Okay, I think that's one. Yep, okay, good. Okay, staph epidermidis. Why can it cause this? What does it produce that can help in causing septic arthritis in patients with prosthetic joints? Biofilm, which is a waxy layer. Perfect, good. Know this step in pathogenesis. Okay, prosthetic joints, think staph epidermidis. Now, can someone tell me the diagnosis and the organism?
Lyme
Good,
disease.
Lyme disease. What's it caused by? The organism.
Borrelia.
Borrelia burgdorferi. Now, can someone tell me what's the name of this lesion? It's a target sign or target lesion. Well, what's the actual name? Erythema, what? Okay, no worries. You don't need to know. Chronicum migrans, okay? You don't need to know that. Yes, you need to know Lyme disease, Borrelia. And someone said tick, good. It is transmitted by a tick bite. Can someone tell me what's the specific tick that can transmit this? If it was mentioned in micro, if not, Adi. Move on. Because there's another infection that's transmitted with another tick. Good. Ioxides tick. There's another infection causing also the Babesia. Perfect. Babesia and Borrelia. Okay, there's also another microorganism, anaplasma, that's carried by Ioxides. For you guys to know, just know Borrelia caused by Ioxides tick bite. Okay, causes Lyme disease. That's it. There's another skin lesion that we'll get to later that's caused by a tick bite, not Ioxides, something else. Can someone tell me what this diagnosis is? Osteomyelitis. Perfect. Now, osteomyelitis, what's the most common organism? Staph aureus. Good. Okay, Staph aureus is a major organism that can cause this. And as I mentioned, in patients with sickle cell, it's going to be Salmonella as the most common cause. Okay, know the differentiating between septic arthritis and osteomyelitis. Very important to tell the difference. Now, with osteomyelitis, usually you'll have pus that forms in the bone. It starts to inflame and go through inflammation. As this inflammation builds up, it will cause compromised blood supply. This compromised blood supply, he said that. Interesting. Okay, go with what? If the doctor mentioned it and you have evidence, go with that. Okay. Well, usually that's interesting. If in that case, I would go with what micro said. If that's what the micro said, it's usually going to be a micro question that asks it. Either ways, it's appealable. Okay. But in what's known is that in osteomyelitis, for sickle cell, it's Salmonella. Septic, it's Staph aureus. Okay. That's what's known. That's what's in step 1 and step 2 and whatnot. Okay. Anyways, as I was saying, for osteomyelitis, you have inflammation that builds up that causes compromise of blood supply. This compromise of blood supply will cause necrosis. The bone will basically be separated from the rest. This is what we called a sequestrum. Here, these white areas are these sequestrums. Okay. And then these black areas are these lytic lesions, which is where the inflammation is building up in the beginning. Okay, there are stages to osteomyelitis. Now this next picture, I want you guys to tell me what this is. Brody's abscess. Okay, it's another finding you see in osteomyelitis. Okay. Now, Brody's abscess, funny story last year is I found out that this existed literally a day or two before the exam, and it came in our exam. So I would remember what Brody's abscess is. Okay. It's basically an abscess collection that can happen because of osteomyelitis. Okay, that's pretty much the basics of it. You don't need to go into more detail with this. Fun fact, because it's important to remember for you guys to know. How old is this patient? This joint? Like, what's the age group? Peds, children, good. Why? Plates, perfect. I want you guys to keep note of this plate very well, because when we get to fractures, I want you guys to know 2 specific ones that happens in peds. Okay. I have no idea what just happened, but anyways, moving on. Let's go with this. What's this image first?
Osteolytic metastasis.
Perfect. Good. Osteolytic metastasis. How do you know? It's multiple spots. Spot here, spot here, spot here, here, whatever. Okay. Osteolytic metastasis. Now, the most common bone tumor is because of metastasis. Okay. It's usually secondary to metastasis. We'll get to what's the most common primary bone tumor soon. Now, in this one, what is this?
Osteoblastic.
Blastic. Good. Can someone tell me the specific tumor or cancer can cause osteoblastic
Prostate.
metastasis? Prostate. Perfect. Prostate is the one that you will need to know in this exam. Okay. Prostate cancer can cause osteoblastic metastasis. Osteolytic is majority of other things. Okay. Good. Now, there is another disease that can cause a similar appearance that you can see in osteoblastic metastasis. Can someone tell me what that disease is?
Paget's.
Paget's disease. Good. Did they mention anything specific to you guys about Paget's disease this year?
It was only in a PBL.
It was a PBL case?
Yeah, it was only in a PBL.
Oh, okay. So I'll ask a bit of questions. Okay, if the doctor said it's important, then I'll ask you guys about it. Okay. If I have a patient who has these features, they're more of an elderly patient, not too much, middle-aged-ish, coming to you complaining that they used to wear a ring, but now it doesn't fit. They used to wear a hat, and now it doesn't fit. What am I thinking of? What disease? Paget's disease. Now, Paget's disease, the cause of it is idiopathic. It's a mixture of multiple stages that can happen. First, you have osteoclastic phase. The second one is a mixture of osteoclastic and osteoblastic. The third phase is an osteoblastic phase, and then the fourth phase is just it settles down. Because of the osteoblastic phase, basically it deposits so much osteoid that it will cause the bones of typically the skull, the fingers, the hands, and the feet. So you get foot size increase as well, to increase. Typically, other than the signs that I mentioned to you guys, they come to you for signs of tinnitus, of hearing loss, something like that. That's Paget's disease. When you think of Paget's disease, just think of this. And know one specific complication of Paget's that can happen later on. We'll get to it in these slides, okay? I'll ask you guys about this. But that's basically the brief summary of what Paget's disease is. Indefinite, but there's a specific one. Now, can someone tell me what this bone tumor is? Now we're going to go into
Osteoma.
bone tumors. Osteoma is good. Are they benign or malignant?
Benign.
Benign, good. If you see a bone tumor that's happening in the skull, specifically in the mandible or in the jaw, think of osteomas. Okay, good. Now this one is very important. What is this tumor?
Osteosarcoma.
Osteosarcoma. What is the most common primary bone tumor?
This is the second most common.
This is the second most common. Good. What is the most common? Multiple myeloma. Perfect. Good. The most common is multiple myeloma. We covered this in here. Now it's second most common is osteosarcoma. Okay, you don't need to know details of multiple myeloma here. But anyways, age is very important to know here. Age, location, and the signs. What age group is typically affected by this?
Like 10 to 20 years old.
Good. Can you have a later onset?
Yeah, but only if you have Paget's.
Perfect. Good. Okay, it's secondary to Paget's, most common. The primary one, the one that happens in adolescence, is typically due to specific mutations that can happen. I'll ask about this in a second. Now, for you guys, firstly, very important is these two images and what they are, okay? There is this one, and then there's one other bone tumor that's very high yield to know what these signs are, okay? So can someone tell me what this sign is? Codman's triangle. Perfect. Okay. Codman's triangle. Very important to know this sign. Okay. The second one is this one. What is this sign called?
Sunburst.
Good. Sunburst appearance. Perfect. This whole tumor, this is the osteosarcoma, and then this, you see all of this that's coming out, this is a sunburst appearance with the tumor. Tamam? Where in the bone does it usually occur in? Which part of the bone?
Metaphysis.
Good. Perfect. In the metaphysis. Perfect. Now, can someone tell me what's the gene mutation that's implicated in osteosarcoma?
RB.
Good. Retinoblastoma gene. Okay. Very important. I forgot if this was in the slides or not, but Dr. Aban really loves these things, so I will mention it. Retinoblastoma gene. Okay. So, moving on. This is osteosarcoma. As we mentioned, it's usually forming in the metaphyseal plate or the metaphysis, sorry, and then it can spread wherever. On the histology features, you need to identify what this pink part is. What is this pink? Osteoid. It's a tumor that's producing a lot of osteoid. That's what this is. Okay? That's it. That's all you need to know about this. Okay. For OSPE, very important to remember these two radiology images. For the rest of MCQ is how they present, age, location, these signs. You might get one of these images or this images, and the fact that it's an osteoblastic tumor that produces a lot of osteoid. Okay, that's it. And primary lesions are retinoblastoma. Later onset is secondary due to Paget's disease. Okay, that's basically the summary of osteosarcoma. Moving on. Can someone tell me what this tumor is?
Osteochondroma.
Good. Osteochondroma. What is this white part? Or this purple part? Okay. These are cartilage. Okay. It's osteochondroma. So it's both a mixture of a bone part and a cartilage part. Osteo, bone, chondroma, cartilage. Benign. Okay. Age is not as important because it's mostly in like the mid 40s, 50s, I believe, where it causes, and it is a hamartoma. Okay. This part over here is the osteoid. This is the cartilage. This is what you see on imaging. Okay. I don't think there's a specific name to this. It's not as important, but if you see this, think of osteochondroma. Okay. So what is this, guys? Chondroma. Okay. Instead of just osteochondroma, we just have chondromas. What's one location that's very specific for this disease? It's very important to remember that it can affect this this tumor can affect one specific location. Phalanx, good, perfect. Phalanges. Remember phalanges, okay, guys? One of the common locations that this can affect is the phalanges. It can affect other things, okay? However, phalanges is a very specific thing it can do, okay? It's a benign tumor of chondrocytes, okay, of cartilage. Tamam, and all these white spots over here is cartilage, and you can see how destroyed this bone is. Tamam. Moving on. What is this? For some of these, I'm gonna rush more faster with just to give you the high yield stuff and move on. The stuff that's way more important, I'm gonna stress on a bit more. That's basically what I'm doing now. Good. This is a chondrosarcoma. Is this the most common primary cartilage tumor? Yes. Okay. Is it benign or malignant?
Malignant.
Malignant. Good. The most important finding is this. If you look at this lacuna, what's in this lacuna? Very important. The most diagnostic histological feature about this.
It has a lot of nuclei.
Nuclei, multiple nuclei. Okay. This is something Dr. Aban stressed on from what I read from your transcript. Very important. This is what gives it its malignant features. Other than that, you have all the other types or other signs of dysplasia, of anaplastic cells. So you have these cells, high NC ratio, hyperchromasia, and all these things, okay? Affects the metaphysis typically as location. For OSPE, I don't think this will come, صراحة, but for MCQ, this is very important. This is very important for OSPE. What is this?
Ewing sarcoma.
Ewing sarcoma, perfect. Ewing sarcoma typically affects what age group?
Kids.
Good. Is there a specific translocation with this? And what is it?
It was
11,
something
22.
Ewing.
Okay, it's 11, 22. Tamam. This translocation is very important. Okay. Now, ignoring the histology and the gross pathology, the most important thing for your OSPE is this radiology. What is this appearance? Onion skin appearance. Good. Onion skin appearance is used so many times, but in terms of bone pathology, if you hear onion skin, you think, okay, I'm going to think of Ewing sarcoma. Where in the bones does it affect?
Diaphysis.
Diaphysis, good. In the shaft of the bone. Perfect. No diaphysis. Any locations when I ask, it's either epiphysis, metaphysis, or diaphysis. These three locations. It's important to tell the difference between them because in the case, you might get this keyword. And you know, okay, diaphysis, the only one that I know it causes is Ewing sarcoma. For the cell histology, it's not really that important to know it, but it looks like a bunch of lymphocytes. That's typically how it's described as. And it's a very, very destructive tumor that's going into the medulla. So that's it. Now this tumor. What is this tumor?
Osteoclastoma.
Good. Osteoclastoma, or another name as mentioned in chat, is giant cell. Perfect. Now giant cell, histological feature, common sense, is you'll see giant cells. Okay. Now, where in the bone does it affect the most? Which part of the bone?
Epiphysis.
Epiphysis, perfect. And what do we call this appearance? If you guys know.
Bubbling soap.
Yeah, soap bubble appearance, perfect. Okay, and it's mostly in the epiphysis. So, key terms. You hear soap bubble, think giant cell. You hear it's in the epiphysis, think of this. Okay, giant cells, they give you the name. Okay, perfect. We're done with tumors. The ones I need you guys 100% to know, this one, Ewing sarcoma, and osteosarcoma. These three are high yield in OSPE. If they bring anything for bone tumors, it's these three. Know these. Now we'll go into more of MSK stuff and fractures and dislocations, all these things. We're gonna go quickly in these. That's the first one, and I will just tell you the important ones and the key things to figure out or to remember about all of these. The first one, guys. Can someone tell me what this dislocation is? Is it anterior or posterior? Anterior dislocation. Good. This dislocation, posterior. Perfect. Now, anterior dislocation, if you can see it, it's if someone's having this dislocation, it's one of the most common dislocations ever. In terms of like shoulder dislocations, most common dislocations typically, it's usually that the joint is going to go anterior, inferior. So it's going to go out of the acetabulum and the glenoid fossa and goes down. It's not going to be articulating anymore with the acetabulum, okay, or the joint capsule. In the case of posterior, what do we call this sign?
Light bulb.
Light bulb sign. Perfect. Okay, this is posterior dislocation. If you see a light bulb sign, think of well, it also looks like a balloon from my drawing, but anyways, posterior dislocation. Okay, it's less common, and I read from your transcript that's more seen in epileptics apparently. So if you see a guy having epilepsy or a seizure, just think of posterior, okay? Because it's very distinctive. I don't know why. So anyways, that's the dislocation that you guys need to know. Now for the fractures, and these are very important that you guys identify these fractures. What type of fractures is this?
Tibial.
I don't want the
fibular.
bone. I don't want the bone, but I want if it's oblique, spiral, longitudinal, like that type. Okay, but this is transverse. Perfect. Transverse if it's going line horizontally. Okay, so that was where that fracture was. If you see, for example, something like this is transverse. Okay, this is transverse. This is fibular fracture. Tibia is this one. Okay. Anyways, this is a transverse fracture. This one,
Oblique.
oblique. Perfect. Going diagonally. Perfect. Next,
Spiral.
spiral. Good. It's going around like this. You can see it's spiraling around the bone shaft. Perfect. This one.
Longitudinal.
Good. Perfect. Longitudinal. This is the only image that I've ever seen actually. From longitudinal and specific. However, it's not the most important one that I want you guys to know from all of these. You need to know how to identify all of these. If you have any questions on how to identify them, just feel free to stop me. This is longitudinal. Tamam? This one. I would give you that, but I want something very more specific. Avulsion fracture. Good. Avulsion fracture is basically where you have a site where a tendon attaches to, and due to any reason, this tendon will pull on the bone. This causes the fracture. Okay. So in this case, it could be a tendon, could be a ligament tear, very severe ligament tear that can cause it. But anyways, it can happen. For example, typical areas that this happens in is in the foot and the hands. Okay, but usually, very commonly, is a foot that these things can happen. Or they bring the picture of the fingers or the tarsals. Okay, so I wouldn't say it's a type of transverse because there's different degrees. Because sometimes with these fractures, that the entire piece of the bone can dislocate off and can just detach. Okay. Usually they won't bring both together if it's either transverse or avulsion fracture. To tell them apart, as I said, usually either they have one sec. So for example, this one, you can see that the entire part of the bone is actually getting off. Okay, there's a line going through the entire bone. Tamam. And transverse, it's not usually going all the way for this one. Okay, and it's usually affecting these small little bones. Okay. So now this fracture, can someone identify this fracture? Torus fracture. What's another name of it? Buckle. What age group does this affect? Kids. One of two fractures that can cause in kids, and it's important to remember that. See, this is the metaphyseal plate. So, anyways, this is over here a buckle fracture or a torus fracture. Okay, it's usually if someone's falling downwards like this straight, okay, or like this straight. When they're falling downwards like this, because the bone is still very weak, it compresses the bone like this and it pulls that like this way. So, that's what causes the torus fracture. Okay, if you guys want me to draw it, it's better. That's basically if I have this bone right here, if it fractured because it's falling this way diagonally, vertically, it's gonna do something like this. This is a torus or buckle fracture. So the bone won't actually break. Another very important one that happens in children is, what is this? Green stick fracture. Perfect. Green stick fractures are very, very important, and you guys need to be able to identify this very well. تمام. High yield, very high yield for your exam. Green stick fracture. Again, it happens in children. So the same concept, because the bone is not going to break now, it's going to bend. Okay? Because it's a bit different in children with how their bones are formed. Tamam? Good. What is this fracture, guys? There's two words I need you guys to say about this type of fracture.
Comminuted.
Comminuted, which means what?
That it's an open fracture.
Okay. You mentioned both of the terms. Comminuted just means that it's multiple fragments. Okay. So you can see this bone is completely destroyed. You can see a fragment here, this one big one, another one here, another one here, and another one here. An open fracture is a fracture that opens to the outside world. How do I know that this is an open fracture? You can't see the bone that's going outside, but how do I know this is an open fracture?
There's bulging in the skin.
Other than that, air bubbles, okay? These air bubbles tell me that it's open, okay? Maybe the image missed the part that's actually protruding outwards, but because there's air bubbles, it tells me it's open. It's exposed to the outside world, okay? This is what the comminuted fracture is and what an open fracture. So you, by definition, you know what a closed fracture is and simple fracture, okay? It's either one piece of bone, like all the types of fractures we've seen, or just one cut. That's a difference between non-comminuted bones fractures, and then closed fractures is all the ones that we've seen already. Okay, this is open because it opens to the outside world. Now this one, I don't want you guys to tell me what the type of fracture is, but I want you to tell me what the specific name of this fracture is. So I don't want types. If you want me to give you a case to help you out, I'll tell you. Okay, case. So you have any age, doesn't matter. Someone who's riding a bicycle and then they tripped and they fall on an outstretched hand. And then they have a severe swelling in their wrist. Okay. And they have severe difficulty in extending their hand. Colles fracture. Perfect. Distal radial fracture. This is Colles fracture. One of the fractures that you need to identify. Just like you see this, Colles fracture. Okay. So your sports medicine, guys, this year is very different. And LGDs also are very different from any of like the past batches. You guys have a very different set of lectures. I took out I honestly don't know what they might ask you from it. So it's very different. But since this was brought, is one of the more high yield ones. Okay. So I brought this and put this. Okay. Moving on. What type of fracture is this? I'm asking about the type of fracture now. If you guys need a hint, look, it's a regular fracture, okay? The bone density is low, and there's these cysts. Pathological, perfect. This is a pathological fracture. Pathological fracture is due to a secondary underlying disease, okay? So for example, you have osteopenia, osteoporosis, you have decreased bone density, pathological fracture. Metastasis, pathological fracture, okay? Or like tumor that goes. Osteomyelitis, if it causes a fracture, same thing. TB, when it spreads, causes a fracture, pathological, okay? You get the idea. The way you can tell it is just by looking at, okay, this is a pathological fracture because there's decreased bone density, and you have these lytic lesions, or the area that, like, cystic lesion that I circled, okay? So to remove it, if you guys want to see it better, you can see this clear cystic area, okay? That can tell me this is pathological. So, moving on. What is a diagnosis of this? This is rickets. To answer your question, it very depends on the stage. However, for example, in any later on chronically, you have fibrosis, calcification that occurs, so it appears more bright. However, earlier on, it may appear more black, a lytic lesion, something like that. Okay, so it varies. I wouldn't like go off of an X-ray to say if this is inflammation or not. I would do something like an MRI to tell me if there's inflammation going on. Okay, so this is rickets. I don't know if this will come or not, but this is something very specific in your radiology lecture, so I brought it. Rickets is due to vitamin D deficiency that happens in children. Most common presentation, bowing of the legs, okay, and may cause pathological fractures. Here on X-ray, the thing that's mentioned here is metaphyseal cupping. Okay, it's a sign that you can see on with rickets. It's called metaphyseal cupping. Okay, and that's all I need you guys to know for rickets. I don't think it was emphasized as much in your block. I could be wrong, but that's all that I can remember from what we had last year. Okay. Now this one, low yield, but it might come in your OSPE, and it was. Just remember to note for you guys, anything that's mentioned in red in your radiology lecture, make sure you walk into the exam knowing them all, the red stuff. Okay, very important to remember the red stuff, and I brought majority of them here. Good. So I already mentioned hemangioma. What is the sign, or what sign do we use to say that this is hemangioma? Polka dot or salt and pepper. Okay, this is the hemangioma, guys. Salt and pepper, the white parts, and then the black parts. Salt and pepper. Salt and pepper. Good. Or polka dots. Just know the picture. You don't need to know the details of what this is. Okay. Know the image. Like ingrain this. Okay. Moving on. Now these two could come. I'm not sure if they will. But first one is, what is this specifically? What is this showing? This is MRI. That's showing a specific diagnosis. ACL tear. Perfect. So someone who let's just say he's most likely playing non-contact sports, suddenly stopped, and this is what caused ACL tear. The usual presentation is a sudden pop that happens, and then hemarthrosis, bleeding that occurs in the joint immediately. A key feature is someone who's playing non-contact sport or playing sports, and then all of a sudden stopped on a standing foot or a planted foot, and this causes the pop sensation, and this pop will then be followed by bleeding into the joint. Characteristic of ACL tear, okay, until proven otherwise. You do an MRI, which is most common thing that you use to look for ligament tears. After X-ray, you do MRI, and you can see this. This is the anterior cruciate ligament, which goes from the lateral part of the tibia, the femur, to the anterior part of the tibia. Okay. Now this is a normal one. You could see that it's a complete line going from the femur to the tibia. In ACL tear, can you identify this line properly? No. Okay, so this tells you that there's an ACL tear. Also, there's edema, there's swelling, and this gives you signs that this is an ACL tear. Now, what's this one? Yeah, this is the ligament. You can see this part over here. This is the ligament. Okay, this line. Good. This is a PCL tear, the opposite. More common one is ACL tear. If you have a case, it's most commonly ACL tear that happens. PCL tear, it's another one that happens, but there's no like specific case that happens with it. The differentiating point is by imaging. Okay, that's how you really know and know this is ACL versus PCL by imaging. Imaging, you can see that this is going from it's specifically medial part of the femur to the posterior part of the tibia. It's going posteriorly. You can see that this is, let me actually get a pen. This is where the ligament was, and this is what the other part is. You can see how it disconnected, so it's a tear. The major part you differentiate is by imaging. However, if you have a case that I mentioned for ACL, think of ACL injury, but you have to do imaging to exclude. Okay? So, okay. Now, can someone tell me the diagnosis of this very high yield disease? Dermatomyositis. Perfect. Good. Now, dermatomyositis affects two systems typically. You have dermatology, myo, muscle. What group of muscles is affected in dermatomyositis? Okay. The group of muscles that's affected in dermatomyositis and also polymyositis is the proximal muscle group, shoulder and the pelvis. Okay. These are the two areas. Now, can someone, let's go by the signs one by one. What is this sign called? Okay. This is shawl sign. Shawl is, you know, the thing you put over your, like if it's the winter now, so you put this thing over your head and you wrap it around your neck. This is what a shawl is. So it's around the neck as if you're putting a shawl. Okay. Tamam. Exactly. Okay. This one was the one you mentioned, which is the V sign. Tamam. This is the V sign. What is this one? Heliotrope sign. Perfect. Good. And what are these signs? Gotron papule. Perfect. Dermatomyositis. Can someone tell me the antibody that's varies from your slides, although there's more, but there, can you just tell me one antibody that's important in dermatomyositis to diagnosis? This is patho. Anti-Joe and anti-me too. Okay, Joe 1, me 2. Okay. So to make your lives easier, I put this slide. Guys, very high yield to know all the antibodies, the most specific one, the most sensitive one for each of these diseases. Super important, guys. So I put this slide. This is while I was studying, I came across this and I decided to put this. Okay, very important to know all of these. Okay, this is it for MSK. Before I go to Derma, are there any questions? Anything you want me to cover again? Anything? Tips, very important is know the antibodies very well. Okay, like know what's more specific, what's more sensitive, for each of these rheumatology diseases. Okay, and systemic diseases. Know the age groups are very important in MSI because majority of them are autoimmune diseases and stuff. So you need to know, like, okay, if I'm thinking of a 30 to 50-year-old patient with signs of arthritis as a female, I think of rheumatoid immediately. If it's someone who's in their 60s, female, more common, then I think of osteoarthritis. So these like key terms, know them well. Other than that, I think also from pharma for you guys, DMARDs, know them by heart, what they are for to treat. Know DMARDs very well. I know the mechanism for treating gout, know the drugs very well. Know the side effects. And for osteoporosis, know, for example, the side effects of the drugs. Who taught you guys drugs used for osteoporosis? Okay, Sama. So, know, for example, if someone has osteonecrosis of the jaw due to the drugs, two drugs they're taking in osteoporosis, what two drugs am I thinking of? Osteonecrosis of the jaw. Bisphosphonate and one more. Monoclonal antibody.
Denosumab.
Denosumab, perfect. So, like, know these very important side effects, very crucial to know them. And then when we get to derma, we'll get to it. Clinical, typically his questions are mainly focused on antibodies and mainly focused on just, like very detailed stuff. Okay. Um, like, for example, how do you tell the difference between rheumatoid and osteoarthritis and stuff like that? So this is for clinical. But usually if you covered pathology well, you'll be fine. Like you'll be fine for clinical, it should be easy points. Just know the antibodies very well. I'm warning you guys it's important to know the antibodies. He loves to ask about them. I know, for example, rheumatoid, if it's systemic, what systemic signs? And something I actually forgot to ask, ankylosing spondylitis, it has two very specific systemic manifestations. Can someone tell me what they are for ankylosing spondylitis? Uveitis and one more. Good. Aortitis causing aortic regurgitation. I have no idea what just happened on my camera. Anyways, um, anti-CCP and rheumatoid factor, no. They are both sensitive for rheumatoid arthritis. However, CCP is more specific for rheumatoid. Okay, that's what makes it the best antibody to use. Because rheumatoid factor, as you can see from this this chart, is positive in many other diseases. Okay, well, anti-CCP is a positive. It's positive in Sjogren. It can be, but it's not specific for Sjogren. But it's more specific for rheumatoid. Tamam? That's what's the difference between these antibodies. Okay. Do you guys want a break? Yes, they are. Do you guys want to break for a bit and then we go to derma, or do I go? Okay, we'll continue then. على طول. So, derma, probably the more complicated part of MSI, at least for majority of us last year, suffered a bit. But inshallah, I'll try to simplify this as much as possible. I start with very basics and then we go to the diseases. Okay. So by the time we get to the diseases, I want you guys to tell me everything. Okay. Let's start. Bismillah. Let's start with this. Normal skin sample. Okay. One by one. What is this layer called? Dermis. What is this entire layer called? The entire thing? epidermis. Good, we agree on that. Now, the dermis is connected to the epidermis. This is called the dermal epidermal junction, between the dermis and epidermis. Cool. What will connect the dermis to the epidermis? Hemidesmosomes. Perfect. Good. Now, a couple more things about the dermis. Dermis, does it have blood vessels? Yes. Important for specific signs later on. That's number one. Number two, the epidermis, does it have blood supply? Or blood vessels in it? No. It has a blood supply, obviously, or else it die, but it doesn't have blood vessels going into the epidermis. Tamam? That's number two. Now, one more thing about the dermis I need you guys to know is that these are two more things, actually. Blood vessels, from it, you have epithelial cells that come out of it. Or sorry, not epithelial cells. If you have an inflammatory disease, lymphocytes will come from the blood vessels towards the site of the disease or infection. Okay? Because a lot of these that will have immune responses will be something like dermal epidermal interface or interface dermatitis or something like that, interface inflammation, something like that. Okay, at the dermal epidermal junction. Why? Because it goes from the dermis upwards. It's not the axis, upwards. Okay, now you see this part of the dermis, it's going into the epidermis. What do we call this? Dermal papilla. Perfect. Now let's go into the epidermis. Okay. Now in the epidermis, you see firstly the part that's going into the dermis. What do we call it? Rete pegs or rete ridges, whatever. Okay, rete pegs. So this is what's the difference between dermal papilla and rete peg. Moving on. Now I need you guys to identify the layers of the epidermis. The first layer over here, which is the very first one, is what? Stratum basal. Okay. Then plus minus and spinosum. These darker cells, granulosum. Tamam. This thin one, very thin one. You see this layer of keratin, lucidum. Then all of these is corneum. Okay, to repeat, you have basale, yeah, perfect. That's a good mnemonic to follow. Okay, basale, spinosum, granulosa, or granulosum, lucidum, and then you have one more, which is corneum. Tamam? Good. Now, within the epidermis, you have these brown cells. What are these cells that contain a pigment? Melanocytes. Tamam? That's number one. These darker cells are called what? From the stratum granulosum? Or just it's in the stratum granulosum, okay? That's most of what I need to know, because if it's a darker cell, if it's increased, I want you guys to identify what this is called, okay? But this is later. So now, in the epidermis, how are the cells of the epidermis connected to each other? Desmosomes. Perfect. Good. Desmosomes. Tamam? Good. Now, I will ask you guys certain things. Okay. If I have this entire thickness of the epidermis thickened, increase in size, the entire thing, what do I call this? No, all layers. If all layers are growing, this is called the entire thickness of the epidermis. Is acanthosis. Okay? This is acanthosis. The entire, all layers, not a specific layer, all layers are increased acanthosis. If only the stratum corneum increased in size, what do I call this? Hyperkeratosis. Most of the keratin, the dead keratinocytes, are going to be in the stratum corneum. If this keratinization increased, we call this hyperkeratosis. Okay? Let me know if I lost you. This cell or this cell? One or two? Okay, up. What I wanted to mention is the stratum granulosum, which I'm going to talk about now. These darker cells are the layers of the stratum granulosum. If the stratum granulosum increase in size, what do I call this? Or increase in thickness, what do I say about this? Of the stratum granulosum. If it increase in size, what do I call this?
Hypergranulosis.
Hypergranulosis. So you see these dark cells, that's how you identify it. If there's more, like 4 layers now of these, this is hypergranulosis. Okay? That's how you identify this layer. Good? Okay. Now, as I said, the stratum corneum should have dead keratinocyte, meaning I'm not going to see any nuclei. If you have increase in size of the stratum corneum with nuclei, what do I call this? Parakeratosis. Okay? Moving on. If I have, usually keratinization goes from down to up, صح? Right? If there is hyperkeratinization that's occurring below the stratum granulosum, what do I call this? Dyskeratosis. Cool? Okay, good. Now, what if I had swelling inside the swell? Not outside, inside the cell. What do I call this? The other one. Okay, swelling inside is hydropic changes. Swelling outside is spongiosis. Dyskeratosis is basically where you have hyperkeratinization, but however, usually if I say hyperkeratinization, you're thinking about this layer, صح? Dyskeratosis if you have hyperkeratinization below the stratum granulosum. I'll get to specific images later, don't worry, and I'll clarify these concepts. However, I want you guys to be very familiar with these terms, okay? So good. What is spongiosis? It's swelling around the cells, okay? It's not inside the cells, it's between the cells. So intercellular, not intracellular. Perfect. Good. Now, what if I had a pathology that causes cleavage of the desmosomes, and the cells will start to separate from each other? What do I call the separation? Blister is what you would say, but I want the histology finding. The cells will start to separate from each other. Perfect. Acantholysis. Good. What's acanthosis? Someone say in chat, what is acanthosis? Thickening of the entire epidermis. Acantholysis is separation of the cells because of the desmosomes are now not attached anymore. Good. One more is these melanocytes. Before I move on to the other slides. These melanocytes, if they start spreading along the entire basal layer like this, what do I call this? In histology findings specifically. Lentiginous. Okay. Yes. Okay, this is what lentiginous is. The melanocytes, we talk about them later in a bit, but usually it will spread like this. Okay, if it spreads this way, it's bad. This way is called a lentiginous. Okay, where the melanocyte, when it goes through a hyperplasia, it goes like this. Okay, radially. Okay, that's lentiginous. If I lost you, let me know. However, I'm going to go through each of these things one by one with its own specific pictures, and I'm going to pinpoint the very important ones. Tamam? Now this one is just a diagram explaining everything, but mashallah, you guys mentioned almost all of it. There's one more cell that I didn't have here, but a Langerhans cells. Now these Langerhans cells are important for what specific pathology? Which of the skin disorders? Hypersensitivity. Good. They're basically antigen presenting cells. They go upon first exposure, they see this new thing. Okay, I don't like this thing. I'm going to pick it up, go to the lymph node. Goes to the lymph node, tells these T cells, like, hey, look at this. I don't like this. Then you're going to say the T cells are going to start to form memory T cells. Memory T cells is going to go back to the skin. Upon re-exposure, the T cells are going to be like, okay, I don't like this guy. He's back. I'm going to tell the B cells to start secreting IgE. IgE goes to mast cells and then histamine release. Hypersensitivity. Tamam? All of this starts from Langerhans cells. Okay, I went off track, but we'll get to it later again. Okay, so don't worry. Tamam. These are important to know. Okay, not as much, but it's good to know the definitions. So what is this? I know it's written, but I'm going to quickly do that. It's not as important to just tell what it is by this picture. It's a very bad picture. However, I want you guys to know the differences between these. This first one is a macule. Tamam. The second one is what's a bigger version of a macule?
Patch.
Good. Patch. Okay. The difference between them, the size of 5 millimeters. Below 5 millimeters of a flat lesion is a macule. Above is patch. Okay. Stick to the lectures for this one. I know it's annoying that there's a difference in resource. Stick with their lecture. Like the thing that I study from step one a lot, from the step one resources, especially last year, and I went through this difficulty of like the sources saying different things. And the end of the day, for your Al-Faisal exam, stick to what the slides say. Okay, does not matter. Stick to what the slides say. Now, if it's a raised lesion, less than 5 millimeters, what do I call this? Papule. Good. If it's larger than 5 millimeters, what do I call this? Nodule. Good. If a bunch of papules join together, what do I call this? Plaque. Good. That's pretty much it. Okay. These are the 5 that I need you to know. The reason, I don't think these specifically will come in your OSPE or as a form of question, but I need to complete, I need to cover this. Know the differences in size, know if it's a raised lesion, know if it's a flat lesion, know the differences in sizes. Less than 5 centimeters if it's flat, or less 5 millimeters, sorry, if it's flat, a macule. If it's raised, papule. If it's bigger than 5 millimeters, flat is a patch. If it's raised, it's a nodule. If a bunch of papules join together, it's a plaque. Okay. Now, let's just say one of those papules was filled with pus. What do I call this? Pustule. Okay. So which is what this is. Tamam. Let's just say you had a fluid-filled papule. I wouldn't say papule, but lesion, vesicle. How about if it's very, very large one that's filled with fluid? Bulla. Another word of bulla is blister. Okay. Blister most commonly happens with burns, for example. You might find the region is swelled, but that's just a blister. Now, something that happens with hypersensitivity, anaphylaxis, is a wheal. Okay. More commonly, you'll see it if someone does a skin test, right? A skin prick test. Once they inject it, you see the area of the skin raise up. That's a wheal. Okay. So that's what these are. Tamam. The only reason I have these are because I'm going to mention what these are, and I want you guys to be familiar with what these are when I mention them later. Like, for example, in HSV, we have vesicles that form. In pemphigus vulgaris, we have blisters that form. Now you know what they are. Tamam? Good. Now, these blisters, certain diseases, if you pop this blister, it can form an erosion. Okay? So that's something to note. We'll get to this. Now to go more. Now let's just say someone has a very itchy, dry area of skin. Okay? This is what we call a scale. Okay? Now let's just say someone has eczema. They started to itch. Later on, it became very dry and gray. What do we call this? Lichenification. Good. Okay? This. Now, let's just say someone had a lesion and they started to itch it a lot, that it started to bleed. Like you can start to see the redness from underneath. What do we call this? Excoriation. Perfect. Last thing is if you have separation of the nail from the nail bed, what do we call this? Ankylosis. Good. Or onycholysis. Okay, scale, lichenification, excoriation, and onycholysis. Usually excoriation, how we describe it is that someone was had like a very itchy disease, like for example, eczema, and then you start to see bleeding that's coming out of it. Erosion and ulcer, we differentiate based on the amount of layers that happens. Okay, that's how we describe this thing that happens. However, the like depthness of the wall is what we describe it as either erosion or ulcer. Okay, so lichenification, common disease, as I mentioned, is asthma. Sorry, not asthma, eczema. It's part of the atopy that happens. And onycholysis. What disease is this seen in? Very important disease. Psoriasis. Perfect. Good. Just know the terms for this. I don't think fungal infection is something different. I'll get to that. Okay. What the fungal infection is called. It's not called onycholysis. So, anyways, the definition terms. I'm done with like the macroscopic ones. I'm gonna go into the microscopic. Is there anything that you guys need me to repeat? There's everything clear. I know this is the hard parts of derma. Tamam. Okay. As I said, OSPE purposes, I don't think any of these will come. Okay, you might get like a vesicle or a pustule as a picture, like from these same images. You may get a blister and say what this is. It's a blister. Okay. And for the plaque and everything, they might give you a size. Okay, it's not fair if you just look at it. But basically, if it's a very big papule, if it's very small, sorry, it's a papule, very big version, it's nodule. Anyways, let's move on. Now, if I have a lesion that only extends, it doesn't go deeper than the mucosa. What do I call this? Erosion, okay? Or just the epidermis. Does not go deeper than the epidermis. Mucosa and submucosa stuff in GI. I'll teach you guys in GI. This one is erosion. It's the epidermis. If it goes deeper than the epidermis, what do we call this? Ulcer. Good. Now this one. I'm gonna describe it and you tell me what this is because the image is the exact same. Okay, there's no difference in the image, but however, I'm gonna get to a lesion later on that I'll show you that this is specific for this. But Dr. Abrar put the same image. So, if it's intracellular swelling, good, hydropic. Intercellular, spongiosis, good. Okay, that's it. That's pretty much it for this. Now, um, let's go through these. Now, something I actually did not mention is what this is. If you have lymphocytes going into the epidermis, what do we call this? Good. Exocytosis. Not as important in terms of like the pathologies that I'm going to describe. However, it's just good to know. Okay, as a picture. So these next very important for OSPE. Very important. What's this one showing? If it's separating between the these cells are lymphocytes. Okay. The very dark nuclei ones, these are the lymphocytes. So, and you can see some of it coming from here. And anyways, like coming from here, going up, and you can see this is a blood vessel, صح? Right? This is a blood vessel, and you can see around the blood vessel is a bunch of these lymphocytes. Okay, so this is like exocytosis going from the dermis to the epidermis. Okay, this one, as you guys already mentioned, is acantholysis. Acantholysis happens due to cleavage of what? Between these cells, desmosomes. Okay, important to remember desmosomes, acantholysis, because there's a specific pathology that I'm going to say again. So, now this one over here is showing what? Thickness, increased thickness of the stratum corneum is what? Hyperkeratosis. You can see that this is where the basal membrane is, the basale. You go all the way over here. You can see this pink area over here is why is it pink? Is because there's no nuclei. It's all dead. Okay, that's why it's pink. This whole area is huge. It's not supposed to be like this. Look at this part of the skin. Nothing. Okay. Why is that the case? Is because of hyperkeratosis. So, increased thickness of these stratum corneum or the keratin. Now over here, okay, I'm going to pinpoint some markers. This is a basal layer. This is the stratum granulosum. Now tell me what's wrong. This keratosis. You see all of these? All of this, all of this, all of this. Okay, these are all keratin. There's hyperkeratosis that's happening below the stratum granulosum, meaning this is dyskeratosis. It's not supposed to be there, right? So this is dyskeratosis. So all clear till now. I'm going to keep stopping for derma because it's important that you guys get all of these terms. Okay. Below, yeah. Below is the spinosum. Obviously, the least layer is going to be the basale. Okay. Okay. Now, this picture is high yield, you know. All of these, by the way, are very important to remember. This layer is very thick now. You can see the stratum granulosum is thickened. What do I call this? Hypergranulosis or granulosum. Yeah, granulosis. So, now you can see here by this stain, I'll mention the stain later, but this stain, you can see that the melanocytes has increased in number radically or radially, sorry. What do I call this? Lentiginous. Good. Now, you can see this. These lesions are finger-like projections. What do I call them? Papillas. Good. Papilla, you have these finger-like projection with a fibromuscular core. Okay, that's a very fibrovascular core. Sorry, fibrovascular core. That's a very important characteristic or feature or a description of papilla. Okay. Now this one is it's a picture that was in your slides. So we'll get to an actual disease that has this, but this is acanthosis, which is complete thickness of the entire layers, all the layers of the epidermis. You can see here it's like going from the basal all the way to the stratum corneum, and you can see all the layers are thickened. So this is acanthosis. Okay. All clear? Yes. Okay. Tamam. Now over here, you can see that the stratum corneum is very big. However, there's an issue with the stratum corneum. What is it? Nuclei. Good. So what do we call this? If there's retained nuclei? Parakeratosis. No need to hyper. Just parakeratosis. Okay. Good. Now, this one is the least important one from all of them, in my opinion, but this is something called vacuolization, okay, where it forms vacuoles inside, which is basically inclusions, okay? Not as important. I have not seen much about this ever. It's just a term to remember. It's mostly important in like infections, specific ones, but I haven't seen it in a lot of things, okay? But nothing from what we're going to describe will have this, so I don't think it's as important. Good. We're done with the. It looks very similar to it. However, like for hydropic changes, usually hydropic changes are signs of, if you guys remember from POD, is like signs of reversible cell damage. So you might think of like features or signs of that. You might see pycnosis that can happen later on, and so on and so forth. Vacuolization, صراحة, I don't think they're gonna bring this, not gonna lie. They might bring spongiosis and ask about it, but they usually don't ask them. Okay. They might ask it in the context of a pathology. Like, for example, one that's coming up very soon is what is a feature that you see on histology is spongiosis. But to identify these, the most important ones, parakeratosis, hypergranulosis, lentiginous maybe, papilloma is important, acanthosis is important, hyperkeratosis is very important, and dyskeratosis. This is also, but the rest is, it might not, but these are the high yield ones that you must know. Okay. Now we're gonna go into the pathologies, each one. Okay, I put the major ones, and the stuff that I'm gonna ask you are the most important stuff about each one. If it's confusing, stop me. Let's go. Number one. What is this? Urticaria. Perfect. Now, can someone just mention, actually don't need, but basically on the skin, like the gross features, you might see a bunch of papules, a bunch of nodules, and stuff. Basically they're Reeves lesions, and it's because of what underlying cause? Good. Hypersensitivity. Okay. Usually type 1. Yeah. Usually type 1, IgE mediated, you have histamine that's causing this raised lesion. Okay. You might have IgG as well due to chronic type 4 hypersensitivity, maybe. Okay. But usually urticaria is a sign of anaphylaxis. If you see it's broad, like diffuse urticaria, signs of anaphylaxis, which is type 1 hypersensitivity reaction. Now, what's important for you guys to note out is this. Is there anything wrong with the epidermis in this picture? Epidermis. Yes or no? Good. No, there's nothing wrong. Okay, it's intact epidermis. The issue is in the dermis. You can see some swelling that's occurring in the dermis. You see all these white areas. Okay, if I can pinpoint a specific blood vessel, maybe like this one over here, but you have some lymphocytes that's coming out. Okay, this one right here, there's one right here, here, and so on. Okay, It's coming from the dermis. It's going upwards. However, there's no interface dermatitis. There's nothing wrong with the epidermis. Okay, this is urticaria. Now, something to describe about the stratum corneum is it looks like a basket weave. This is something Dr. Abrar mentioned. It's a basket weave appearance. This means it's an intact epidermis. Tamam. Now, can someone tell me what this disease is? It's eczema. Okay. I can see why you might think impetigo, but it's not impetigo. Okay. I'll show you a picture of impetigo later on. Okay. So eczema, when it's in children specifically, in infants and babies, commonly affects the face. Okay, commonly affects the face. You have these very itchy lesions that on, like, for example, in children, not babies, in children, adults would be on the flexor surfaces, and it will undergo lichenification, which is these chronic lesions. Very itchy lesions. They're mediated by what? They're atopic. So that means it's from IgE. Okay. E. More importantly is E, because they're atopic. Okay. Atopic means you have asthma, which is IgE. Remember that. And then you have eczema. Okay. IgE, more importantly. Now, in the histology findings, what do I call all of this? This is a clear picture showing you spongiosis. Perfect. It's different because urticaria is a response that happens very suddenly due to mast cell desensitization and release of histamine. The histamine that causes the itchiness, the raised lesions, everything. So it's usually due to some, like, for example, if you have anaphylaxis. So when you have, you eat something that's you're allergic to, you might get widespread urticaria, flushing, all these signs of anaphylaxis. In eczema, it's one of the atopic diseases. Okay. So usually it's a chronic disease. It's not something acute. Urticaria is something acute finding. Okay. Okay. Now for eczema, I just want to mention very quickly is this. You have, firstly, you have from the blood vessels coming out as lymphocytes, right? Now, these lymphocytes, slowly it will cause this finding over here, which is spongiosis. Over time, spongiosis turns into, there's increased thickness of the entire wall, which is what do I call that? Acanthosis, good. Then you have hyperkeratosis, and then you have dryness. Eczema, something chronic, okay? Very chronic disease. Affects a lot of people. And it's usually, as a key feature for you to know the presentation, is it's related to atopic diseases such as asthma. Usually they come very similar together. Okay? Usually a family history. Interesting. Interesting. I did not know that. Look, the way I feel like I think about it to make it easier to tell the difference is urticaria is something that happens quickly. Okay. And this is a simple way of knowing it. They won't ask you to differentiate the two, but if someone has signs of anaphylaxis, it's usually urticaria that happens. There's a widespread rash and the swelling that happens. If you have eczema, it's something more chronic. It's chronic itchiness that does not have signs of anaphylaxis. Okay. If they ask you, they'll ask about each separately, and they'll ask you just underlying mechanism, which is IgE, hypersensitivity, and so on and so forth. And for eczema, what starts this entire thing is Langerhans cells. That's also another important thing about it. Okay. Slides are a bit confusing when it comes to like how it's categorized. Know them by presentation, know them by pathophysiology and findings. Very different. Okay. Now, this one, I need you guys to know very well. Usually it's in the eczema that it is. Okay. Can someone tell me what this disease is? Erythema multiforme. Perfect. Good. Now, erythema multiforme is now, why is it called multiforme? It's because it's multiple forms. You have papules, nodules, and so on and so forth that can happen. The most important feature of it, like seeing it, is this feature. I need you guys to know this by heart. What do I call these lesions? Target lesions, targetoid lesions. Okay, good. Now, something very specific about this. The center of the red, the darker red, is controlled by what cells? What mediated by what type of cells? Very specific. The center of this. CD8. Good. CD8 cells, T cells, are cytotoxic T cells. That means it causes cell death. So these areas that have those darker areas are actually dead cells. Good, because when we go to the actual picture of the histology, that's what we're going to see. Surrounding it is controlled by what cell? Mediated by what cell? CD4. Good. Know these guys. Okay, they might ask you in the middle, it's CD8, in the periphery, it's CD4. Like, this is an answer. Okay. Usually they might give you like one key picture. Okay. Like, for example, this targetoid lesion, you see it. Okay, I'm going to think of this. Okay. Or they give you the pathology picture. Okay. This block is very heavy on pictures. So they're going to give you, it does look like it, but usually if they're going to give you this one, erythema multiforme, it's this picture. Okay. Now the very high yield picture. Now on histology, we said that this is the dermal epidermal junction, right? What's happening at it? Good. Okay, there's a lot of lymphocytes at these areas. You can see the blood vessels here coming out of the blood vessel going to the dermal epidermal junction, right? At the dermal epidermal junction, you have interphase dermatitis. Okay, meaning there's inflammation, there's lymphocytes at the dermal epidermal junction. And you can see it clearly here. Tamam? Good. Another thing that I wanted to mention. Cool. Is that, as I said, there's CD8 cells, CD4 cells. So you might have apoptosis. Okay, you might have signs of pycnosis. These eosinophilic cells. Okay, that's what this is showing. Tamam? That's it for erythema multiforme. That the main things that you need to know. In OSPE, this targetoid lesion, you need to know that this is erythema multiforme. Okay, need to know this. Tamam. Now this one. Psoriasis, good. Okay. What do we call this lesion over here, the middle picture? Salmon-colored plaques. Okay. So it starts off red, later on turns into salmon-colored, later on will turn into pustules. Okay, that's very painful pustules. Okay, very painful pustules. Now, in psoriasis, you have these findings. You see a patient who has salmon-colored plaques in the scenario psoriasis. Okay. Now, with psoriasis, you might have nail pitting, oncholysis that may happen, which is this picture. Okay, and then you might have other signs, and we already went through one of them, which is psoriatic arthritis. Okay, that might be happening with the manifestations. Okay, usually extensor surfaces, as you can see here, extensor surfaces. So this is differentiated from ectopic, eczema. Okay, so this differentiates these two. Okay, and yeah, salmon colored plaques. A very important description of this. Now, the most important thing about psoriasis is you need to know, absolutely need to know, the important parts in the histology, which is the next slide. Now, let's go through them one by one. The 5 things you see in psoriasis. Number 1 is, you remember these, what are these called? The epidermis going into the dermis. What do we call this? Rete pegs. صح? So what's happening with the rete pegs? Deeper down. So we say this is elongation of the rete pegs. Good. That's number 1. Number 2 is, you can see that there is a very increased thickness, but with the thickness, you have retained nuclei. You can see a bunch of nuclei. So what do we call this? Parakeratosis. Now, within the stratum corneum, you have a abscess formation of neutrophils. What do we call this abscess? Monroe microabscesses. Good. Now, you see here the entire thickness is also enlarged, so you have acanthosis, and then you have something which is this, that in the dermis you have these dermal papilla. صح? This dermal papilla is going up now. So if you look at the actual skin layers between here and all, okay, ignore all of this, but here, for example, from here all the way till here, it's very thin, right? Typically, it's a lot bigger, this area specifically, okay? Because this area does not matter. This area is very thin. What did I say that's in the dermis? Blood vessels, okay? So now, if you start to itch these areas, you will have immediately blood coming out. What do I call this? OSPE sign. Good. Perfect. Now, the last thing is there's this pustule that forms within the epidermis, same exact, like similar to the abscess, which is formed with neutrophils, which is called the spongiform pustules of Kojog. Okay, these are the important findings that you see in psoriasis. This can come either as a SAQ or an OSPE. It's coming. Like, there's no way this doesn't come. These 5 important features of psoriasis. Number 1, perikeratosis, which means retained nuclei in the stratum corneum, elongation of the rete pegs, suprapapillary plate thinning, which makes it easier to have bleeding. And then you have what's it called? Monroe microabscesses, and then you have the spongiform pustules of Kojog. There is one specific finding. I am forgetting the word of this. If anyone knows, I will describe it, and you guys mention what this is. Is if you have areas of trauma, okay, based on this, based on, like, if you have, for example, an area, exactly, thank you. If you have areas of these trauma, in the areas that you had trauma, these lesions can pop. There's 2 diseases that this happens in. One of them is this psoriasis, which is called Koebner's phenomenon. Okay, good. This is where you have areas of trauma that later on will develop the salmon colored plaque. Okay. The other one, we'll get to what that other one is. MashaAllah. Good. You already mentioned it. Okay. So this is psoriasis. Again, extensor surfaces. Usually you'll have extra systemic manifestation, exodermal manifestation, such as literally the arthritis, so it causes seronegative arthritis. Also, you have different areas or different things that can happen. First, it's red, then you have the Kobner phenomena is usually when you have areas of trauma, it can happen at the area of the trauma, is what I understood or what I understand from Kobner's phenomenon. Okay. Another disease is lichen planus, what can happen at the same time. Like it's the same thing that can happen in it. Okay, that's Kobner's phenomenon. Okay. Additionally, as I said, is you have the salmon-colored plaques, very key. You have the oncholysis, the pitting of the nails, and then you have the 5 signs that are crucial to know about psoriasis, which are these. Tamam? Let's move on. This one. Seborrheic dermatitis. Perfect. What do you see on histology? Other than the plug, what's happening with it? Like, look at the thickness here, and then look at the thickness here. Huge. So we'll call acanthosis. This is a clear picture of acanthosis. Okay. Now, is this a disease of the sebaceous glands? No, good. Perfect. Happens in kids, happens in adults. In kids, it's associated with 2 specific diseases, or 2 specific complications, which is diarrhea and failure to thrive. In adults, it has association with a fungi, which is Malassezia furfur, and also a neuro disease, which is Parkinson's, apparently. Okay, so take that as you will. Okay, it's just very random pieces of information, not gonna lie. That's how derma is. Seborrheic dermatitis, all I need you to know is acanthosis, happens in children, so there's diarrhea and failure to thrive. You have it around the sebaceous glands, so it's not a disease of the sebaceous glands. And you have this plug formation, okay? So based on this, you have oil that's being produced, and it forms these oily lesions, okay? This looks like SLE, like a butterfly rash, but it's not. And you can see it's going all the way up here. Tamam? Okay. Makes sense. Okay. Good. Reduce sebum, reduce dopamine in Parkinson's. Okay. Now, this disease. And I want you guys to tell me, how do I remember this disease? Lichen planus. Good. What's the exactly 6 P's? Good. Now, can you tell me what the 6 P's are? One by one. Firstly, what's its color? Purple. And then now you need to describe the actual polygonal is the shape. Good. Peritic means it's itchy. Papules and plaques. And then one more. Planar. Planar just means it's flat. Like they're flat lesions. Okay. You can see it's very flat. Okay. These are the 6 P's of lichen planus. Something about lichen planus is that, does it have oral lesions? What are they called, if you guys know? Or was it Wickham striae? Good. Wickham striae. Okay, that's what the white oral lines, lesions that happens with lichen planus. Lichen planus usually will affect the extremities. Okay, so the hands, the feet, and I think the flexor compartment. Okay, so that's how you tell the two different from psoriasis and lichen planus. It's associated with the Koebner phenomenon as well. Okay, so this is the other one that's associated with the Koebner phenomenon. Tamam? That's how you tell the differences between these diseases. Move on. Next one is this one. What is this disease? Lichen planus. Perfect. What do I call this appearance? Sawtooth appearance. As soon as you see sawtooth, guys, lichen planus. But what are other findings that you can see is what happens with this layer over here. The dark cells are more hypergranulosis. Hypergranulosis. Okay. Hypergranulosis. You can see that it's way bigger here. Way bigger. Okay. Hypergranulosis. And one other thing. What happens with stratum corneum? Increases as well. So what do I call that? Hyperkeratosis. There's this very specific cell that I want you guys to identify, which is this cell. What do I call that cell? Good. There's also another name for it. It's like Sivat body or something like that. I put it in the notes, but I don't remember the exact name of it, but it's something along those lines. These cells are dying cells, okay? Keratinocytes, I think. So that's another feature. Most important thing in lichen planus is you see sawtooth appearance, hypergranulosis, Sivat bodies, exactly. And you see hyperkeratosis. Tamam? These are the signs you see in lichen planus. This psoriasis will probably come in your OSPE. Okay? These are very, very important that can show up. So now these set of diseases. I'm not too sure, not gonna lie with that one. But the most important findings is the ones I mentioned. So I think there's a before we go into this, in your slides in the transcript, there is a slide that shows all of them. And if I can get a definition, I'll send it to you of what that is. So anyways, what is this one? The one on the left? Pemphigus. Okay, what's the one on the right? No oral lesions. That's one clue I'll give you guys. And usually an elderly age, more older than the first one, bullous pemphigoid. Okay. Now, A is what, as we mentioned and agreed on, is pemphigus vulgaris. Now, pemphigus vulgaris will have oral lesions. That's number one. Number two, are the blisters or the bulla strong in pemphigus vulgaris? No. So they can easily rupture and erode. So that's what you have here, erosions. Tamam? So that's what you have in pemphigus vulgaris. We'll get into the pathogenesis and everything later. Tamam? In bullous pemphigoid, the bulla are stronger in this case. Since the bulla is stronger in this case, it will last. I know some of them broke off, but that's probably like later on. But the bulla in bullous pemphigoid is stronger. The reason why is we'll get to it next slide. Why? Okay, that's number one. And number two is there's no oral lesions. That's very important about it. Okay. Now, you want to check about how it looks like under a microscope. Histology, appearance now. And it's very important you know the histology. Now, what is this one? Pemphigus vulgaris. Okay, good. What do I call this finding? The disruption between the epidermal cells, between the keratinocytes. Acantholysis. Good. Perfect. You can see in this more detailed look is that the basal membrane is still intact. The basal cells are still intact, meaning that this is not a disease of what? What's connecting this layer to this layer? What's connecting these two together? Hemidesmosomes. So this is a disease of what? If it's between the cells, the actual keratinocytes in the epidermis. Desmosomes. Good. Here, on the other hand, it's a direct opposite. Okay. In this case, the entire dermis is here. All layers of the epidermis are up here. Tamam? So this is what disease? Bullous pemphigoid. Good. Now let's go into pathogenesis a bit. Let's go pemphigus first. In pemphigus vulgaris, we mentioned IgG antibodies. What do they target? Give me the general name first. Good. Desmosomes. Specifically, desmoglein. Now you have DPAG1, DPAG3. Exactly. Okay. These are desmoglein. Okay. That's what is targeted in pemphigus vulgaris. Tamam? Good. And the key sign is acantholysis. Can someone tell me what this sign is? If I were to put my finger onto this and scrape, the skin will come off. What is the sign called? Nikolsky sign. Perfect. So Nikolsky sign is another sign that you can see in pemphigus vulgaris. Is if I have a bulla right here. Tamam? If this is pemphigus vulgaris, there's acantholysis, meaning that the keratinocytes are not attached to each other now because there's a disease of the desmosomes. So easily, if I think about it, okay, if I try to scrape the skin, it will directly come off. Okay, like because it's not connected to anything anymore. The keratinocytes are just not connected to each other. So it's going to easily scrape off. However, Nikolsky sign is not positive in bullous pemphigoid. The reason why is because the entire layer of the skin is still intact. All the epidermis is still intact. Okay, there's just fluid that's between the epidermis and the dermis. Tamam? Their keratinocytes are together still. It's just like a blister. If you pop it, it'll pop. However, if you put your finger on it, it won't scrape. Okay, it's just fluid filled. That's why it's stronger. Okay, tamam. It's Nikolsky positive in pemphigus vulgaris. In bullous pemphigoid, if the epidermal cells are still intact to each other, however, the epidermis is no longer connected to the dermis. What is the pathology here? What are the IgG antibodies targeting? Hemidesmosomes. Tamam? Hemidesmosomes. Good. Now there are specific ones, I think, if I remember. Can someone say them? Very specific ones. Okay, good. BRAG 1 and 2, I think. Anyways, hemidesmosomes is the most important one. Now, for hemidesmosomes, collagen 18. Okay. Interesting. So, hemidesmosomes is an important thing. Will the bulla rupture if I put my finger on it? No. So this is Nikolsky sign, negative, mine, negative. Okay. Do I have oral lesions here? No. Good. Okay. This, the pemphigus vulgaris, also we call it a not cobblestone, tombstone to your appearance. It looks like tombstones, if you know what that looks like. That's it. And over here as well. Okay, that's another way we describe this lesion. Okay. Now we do immunofluorescence. If I have this left image, what is this image? fishnet, which is for what disease? Pemphigus, good. Here we're targeting for immunofluorescence the IgG that's targeting the desmosomes. Okay, specifically desmoglia. So what desmosomes are, it's connecting keratinocytes together. So if I have these lesions that's affecting the keratinocytes, the desmosomes, you can see this is a keratinocyte, this is a keratinocyte. It's between them, meaning it's targeting desmosomes. So it's positive pemphigus vulgaris. So that's what this is. The other one, it's hemidesmosomes, right? So what is this diagnostic for? Bullous pemphigoid. Why is this bullous pemphigoid? It's a linear line and it's in the basement membrane, right? It's in the dermal epidermal junction. Okay, good. Is everything clear about these two diseases? Because these two are more than high yield. These will come in one way or another. Okay. There are other bullous diseases that I will go for. Some are more important. I'll mention like stuff I remember from it. The subtypes, I'm gonna go for one subtype here of pemphigus vulgaris, or pemphigus subtype. I don't remember like the details of the subtypes, but very importantly is you remember the targets. Okay, so if this is targeting desmoglein 1 or BPAG or BPAG 1, BPAG 3 or something like that, know that this is pemphigoid, for example. Know these specific targets. They love to ask this. Okay, for OSPE's sake, know these images, either these fishnet appearance or the histology. Okay, these two or the histology. This might come as an SAQ as well. So, can someone tell me what this is? If you need a hint, let me know. Okay, good. This is dermatitis herpetiformis. Okay. What is underlying disease is this associated with? This is very important to understand the pathology. Celiac disease. Okay. Brief introduction, brief statement about celiac disease that I need you guys to know. It's IgA mediated. That's number one. Very important thing. IgA mediated. This explains this entire thing. IgA mediated towards gluten. Okay. Specific particles of gluten as well, but I'm not going to go into this. Okay. IgA, yes. So this IgA is what's causing this pathology. That's it. Okay. It's IgA mediated. A. Okay. This is dermatitis herpetiformis. The reason why it's called herpetiformis is that it looks like herpes. Okay. It's very itchy as well. And then you have this over here, which is I'm not sure, actually, I forgot what this was called. Saha. Someone know? It's like a specific name to this. I am pretty sure it's called like intraepithelial cleavage or something. That's what this is called. This cleavage here. I could be wrong. Basically, it's IgA mediated, causes separation of skin. It's another bullous disease. It's very small lesions and it looks like herpes lesions. Okay, these are the lesions. Okay, that's all them. Yes, sorry, thank you. The subepidermal microabscess. That's what this is. Okay, thank you. This specifically. Yeah, it is. The intraepidermal cleavage is in something else in the next few slides. But this is the subepidermal microabscess disease. Thank you very much. Okay. It looks like herpes, very itchy, IgA mediated, associated with celiac disease. These are the most important things you need to remember about this. Okay. So the likelihood of this coming in OSPE is very low. The most important thing to remember about dermatitis herpetiformis associated with IgA and about its association with celiac disease. Okay, that's it. Now this is a subtype of another, type, which is what? Pemphigus what? Very foliaceous. Good. Now it's foliaceous. Now here you have erosions. Okay, this is number one. This whole thing is an erosion. Now over here you have another type of the what's it called? The acantholysis, or the separation of the skin that happens. In this case over here, it's subcorneal. Okay, so below the stratum corneum. That's all you need to know about this one. There are details in your slides, I think. Know the highlighted stuff in your slides about, for example, any specific targets that this targets. I think it targets desmosomes, but there's something specific in desmosomes that it targets. But usually it's not as important. Like this disease is very low yield compared to the other ones. Okay, this is just me informing you about them. Likelihood of this coming, it's only desmoglein 1. Okay. What's it called? The other two, pemphigus vulgaris and bullous pemphigoid, is very important for OSPE. This is less likely to come. Okay, but it might be coming in MCQ as this lesion, subcorneal separation. You think of, okay, this is only targeting desmoglein 1. Okay, that's how it usually should come. Tamam. We're almost done, I think. We have a bit more left. Epidermolysis bullosa. Okay. Is this an inherited disease? Yes or no? An inherited genetic disease. Yes. Okay. How many types do we have of this? 3 types. There are like details of all 3. I'm not going to go into all 3. However, the most important gene mutations that it's seen in this is keratin associated. Okay, so it affects the keratin. Now, in terms of a histology appearance, it's something called intraepidermal cleavage. I don't think this was mentioned in your slides or described. However, it's just separation of the epidermis. Okay, that's it. That's all you need to know for it. In terms of epidermolysis bullosa, you need to know about its keratin association, about the genes. Okay, and it's inherited. That's a key point about this. Okay. Now we go into other diseases. We're done with the bullous ones. Someone tell me what this is. Erythema nodosum. Good. Perfect. Now, erythema nodosum, is it septal or lobular paniculitis? Meaning it's of subcutaneous fat, صح? So is it septal or nodular? Or lobular, sorry. Septal. Okay, so meaning what septal versus lobular means, lobular is the actual fat tissue itself. So you can see this is a lobule, this is a lobule, this is a lobule. Lobule, 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 lobule. Septal is in between. It's a septal paniculitis of subcutaneous fat. Now, is this associated with vasculitis? Yes or no? No. Good. Is this associated with ulcer? Yes or no? No. That's it. These are the important things to tell about this disease. The reason why I can tell this is septal is when I go to lobular, you'll see the difference. Is first of all, the lobules are not affected. It's maintained. It's intact. Okay. There's no granulomatous disease. There's no vasculitis that's happening. It's a disease of the septa. in between. You see the thickness of the septa, it's increased. That's how I know this is septal. Outside in the skin, there's no ulcers. Like this lesion. This. Okay? Thema nodosum. What is this one? Good. Erythema induratum. This is lobular paniculitis. You can see the difference between these two. This one, it's the lobules are maintained. This one's going into the lobules. Okay? It's not like, it's very messy. Can you distinctively say that this is one lobule? No. Okay? So it's a lobular pattern. Okay. And it's associated with vasculitis, yes or no? Yes. Another thing is it associated with ulcers? Yes. Okay. Is this a granulomatous disease? Okay. So if it's yes, then what's this cell? This cell? If it's granulomatous? Dr. Blood loves this. Giant cells. Good. So we're done with this. These ones, I just need you guys to identify, and that's it. Okay. What's the first one? This one. These are all nevi. Okay, so I need you guys to tell me what the nevi are. Congenital. Good. What's this one? Blue. Okay, blue nevi. They put this ruler, blue ruler, just to show you that it's colored blue. I'm gonna start this one. It's very important. You need to know how this looks like because they like it's a very commonly asked one. Okay. This one, top right. Good. Dermal or intradermal one. This one, white surrounding it. Halo. Okay. Good. Okay. Just know how to identify these. Now identify the following. This is a line to separate them. What's this left one? What's the right one? Good. This is junctional. Complex. Good. Is this affecting the dermis? The compound, yeah. No, this is no. This is junction. So it's in the junction. Okay. Is this affecting the dermis and going deep into the dermis? Yes. That's the only thing I need you guys to know about this. There's probably details in your slides, but in terms of OSPE and how to differentiate them, that's all you need to do. So compound, you look at it from outside firstly. Instead of it being a flat lesion, it's a large, I don't want to say pedunculated lesion, but it's like it's a growth outside that makes it a compound one. And then when you do biopsy, you see that it's going into the dermis. It's dermal. So you can see here, this is it in the dermis. This is it in the dermis over here. Okay. If it's flat, like this one, if it's more flat, you take a biopsy, it's going to be in the dermis. However, can you tell that this is a large lesion? So no, you just call it intradermal nevus. Okay. So that's that. Derma is very confusing with how they name things. And there's no way to it. So going through the nevi. This one. This plastic nevi. Good. Okay. What's the mode of inheritance of this plastic nevi? Autosomal dominant. Good. Is there a specific gene that's associated with this? If yes, tell me what the gene is. Okay, interesting. I was looking for a different one. CDK. Yes, that's the one I was looking for. So cyclin dependent kinase N2A. Or yeah, N2A. Okay. This is associated with dysplastic nevi. Dysplastic nevi are dangerous because why? It can give rise to what cancer? Melanoma. Good. Perfect. Okay. Now, what you see on histology is this. What do we say about this green circle, this cell about here? What do I call this sign? Incontinence. Okay. Melanocyte incontinence or melanin incontinence is basically melanophage. It's a macrophage that goes and engulfs it. Okay. So then that's why we call it melanophage. Okay. Other than that, we said that melanocytes, when they spread, they like to spread radially. So what do we call this radial spread? Lentiginous spread. There is dysplastic cells. Other than that, so yeah, you have dysplastic cells, pycnotic areas, and so on and so forth. Okay, so this is dysplastic features, NC ratio, and all these things. And these are nevi, which is a clusters of these cells that's located in the epidermis. Okay, that's it. So it's microscopically, you have multiple of these. Okay, many, not just one. It might look like a halo sign, but the halo is usually pale. This one is not. And that's it. Basically for dysplastic nevi. Major thing that's important about this is it gives rise to a melanoma, which brings me to this. What is this? Melanoma. Now, when we look at melanoma, what gives it its signs? What is this a scary lesion? Let's go in order. Number one is perfect. A, B, C, D, E. What does A mean? Asymmetry. It's not symmetrical. So, number one. Okay. What's B? Border. Is it regular or irregular? Irregular. Good. Color. Just as a tip, there's multiple color. It's not uniform. Good. The more darker areas are the worser areas. Okay. The lighter areas are the better area. When we try to treat melanoma, we see this regression that happens and it turns into these lighter lesions. The more lighter it gets, the better it is. Side note, anyways. What's a D? In A, B, C, D. Okay. What's the size usually? That's dangerous, more than 6, perfect. And one more is E. Good. Now, there are many types of melanomas that we look into in dermatology. The most common type is what? Most common type of melanoma. Give you hints. There's some that appears in the palm. There's some that are just exactly like this. Okay. Superficial spreading, exactly. That's the most common type of melanoma. Superficial spreading. The one that appears on the feet and the hands, what do we call that? Acral lentiginous. Good. These are the two important things. Now, if we want to say how bad this tumor is, what do we rely on? What makes this tumor very bad? If it starts to spread specific ways, it makes it worse. Breslow's thickness, thank you very much. If it spreads vertically, bad. Okay, the more vertical it goes, the worse it is. Okay, thank you. Now, is it associated with specific genes? A lot. Mention like 4. P53, CDK, RAS. One very specific one. Very important melanoma. BRAF, thank you. BRAF is very important. I will tell you this. BRAF is important, okay? You have other ones such as P16 as well, retinoblastoma, all these other random ones. There's a lot of them. BRAF is a very important one because it's now currently getting targeted for treatment. Anyways, so that's BRAF, okay? And that's it for melanoma that I need you guys to know. Okay, and we mentioned all of these pretty well. Good job. Now, this is it in terms of microscopic appearance. Nothing very specific in terms of it. It's just, it's going into the basement membrane. That's what's making it worse. That's what's calling it malignant. And another thing is, like, you can see it's very disformed over here and everything. Now, you can see here that we stained it. What are the stains that we use to stain melanoma? Okay, and then A, that's 100. And HMB, 45, I think, or 44, something like that. These are markers that we use to stain for melanoma. Moving on. Now, there's a type of these benign lesions.
Seborrheic keratosis.
Seborrheic keratosis, good. Now, seborrheic keratosis, the key terms about this is that it's a single lesion, usually. It's a coin-like lesion, waxy, velvety-like lesion, okay? It's a stuck-on tumor, okay? High yield to remember this, guys, please, okay? So now, in terms of its histology, there's two findings. What is this? Keratin cyst. What do we also call it? Horn cyst, okay? It's filled with keratin. This one over here is called an invagination cyst. I will mention this in your transcript. Or like in the slides, it's wrong. Okay, I forgot which one. Well, the way it was labeled, it's not right. This is the invagination cyst. It's invaginating into the epidermis. The horn cyst is this one. Tamam? Know them. Okay? This is seborrheic keratosis. Now this one.
Acanthosis nigricans.
Acanthosis nigricans. What's the most common association with this? Diabetes and insulin resistance. The second thing is that, what's another important association?
Obesity.
Other than that, cancer. GI adenocarcinoma, okay? So it can cause this as a paraneoplastic lesion. Now, the sign that we see here, what do we call this sign?
The valleys and peaks.
Valleys and peaks, perfect. Good. From its name, it's acanthosis nigricans. Acanthosis means increased thickness of the entire wall, okay? Commonly, and then the hills and valleys, that's a very important thing. Now, these lesions are commonly described as velvety lesions in areas like, for example, the neck, in the armpits area, the axillary area. These are important areas for this. Most common association, insulin resistance due to obesity, diabetes. That's it. This one.
Fibroepithelial polyp.
Yep, good. Fibroepithelial polyp. As I said, in a polyp, you have the epithelium and then the fibrovascular core in a polyp. It's a papillary-like projection. Okay, that's all you need to know about polyp. There's not really much about it. Okay, it's a skin tag. Okay, that's very common. Usually in elderly, older with obesity as well, that can happen and stuff like that. Now, someone who's been standing at the sun for very too long. This is the first lesion that came up with them. And they have dry, scaly skin. It's itchy, and it's a very dangerous looking lesion. What do I call this? Actinic keratosis. Perfect. The scenario I just mentioned is a typical way of a guy, presenting with this actinic keratosis. Okay, usually in the face. And this is a horn lesion. It looks like a horn. It's just because of keratin. If you look at its histology, you can see this. If I look at the stratum corneum, there's a lot of nuclei. So what do I call this? Parakeratosis. Perfect. Good. And then you have also signs of dysplastic changes starting because it's a precursor lesion for what tumor? Squamous cell carcinoma. Good. Perfect. Going into that, this guy didn't try to follow up. It was like, I don't care or anything. It got worse and it developed into this. What do I call this?
Squamous cell.
Squamous cell carcinoma. You guys should be masters at squamous cell by now. Give me 2 histological findings.
Keratin pearl.
Number 1, which is the one over here. Okay. Number 2, it's not as obvious. Other than squamous cells. Intraepithelial bridges. Okay. And that's it. Okay. These are 2 important findings that you see histologically in squamous cell carcinoma. The mass, usually on the forehead, typically areas, forehead, the nose, important area as well. Usually on the face, the sun exposed areas, it's usually due to UV light. And it comes as a more of an ulcerative lesion. Okay, as you can see here, black, dark, ulcerative lesion. Okay, squamous cell carcinoma. It looks ugly. Now, one form of squamous cell carcinoma is this. What is this?
Kerato and the volcano one.
Okay. Keratoacanthoma. Okay. So keratoacanthoma, perfect. You described it perfectly. Volcano. You see something like this, it looks like a volcano. Okay. These areas over here are all the squamous cells, and this over here is the keratin. Okay. All keratin. And it looks like a volcano. Okay. That's all you need to know about this. It's a well-differentiated form of squamous cell carcinoma. Okay. That's it. Now this one.
Basal cell.
Basal cell. What's the most common skin cancer?
I think basal and then squamous.
Yes, good. Basal, then squamous. Now, basal and squamous, do they have high chance of metastasis?
Yes.
No. Okay. Usually, no. Melanoma does. Melanoma is ugly. Okay. So that's one. On gross appearance, what we usually describe this as is a pearly lesion with telangiectasia. Pearly, shiny lesion with telangiectasia. What is telangiectasia? Is this these blood vessels? Okay. It looks like a pearl with a bunch of blood vessels. That's it. Now, in terms of its signs on histology, you can see these are the basal cells. It's a cancer of basal cells, and it's forming a palisading appearance. Palisading means just they're parallel. Now, how do I know that this is a tumor? This is a malignant tumor. How do I know based on this image here in the middle? Okay. This is the basement membrane, guys. What's all this done?
Islands.
Yeah, it's invading the basement membrane. Okay. That's the whole point of it. It's not supposed to be here, right? That's it. Okay. This is basal cell carcinoma. Okay. We're done with this. Now we're going to go into micro and we're done. Okay. Very quick stuff. Micro and some of the clinical stuff. This is acne. Okay. Good. This is a bacterium. That's My mistake. This was supposed to be hidden. I ask you guys. That's lucky. Anyways, acne is something that happens with puberty, something that happens with steroids, something that happens with, for example, if you have basically it's because of testosterone that happens. It's most likely because of puberty. Testosterone causes an increase in sebum, that causes blockage, that then you form comedones, and then usually the bacteria that's associated with these comedones are the Cutibacterium or Propionibacterium acnes. Okay. I think got a question on this just as an image, and someone had acne, and what's the bacteria called? So just know what it is. Okay. So that's it. Acne has many stages and forms of it. I don't think it's as important to remember it. Okay. The stages of acne, there's a lot, there's too much, but there's more dangerous versions. There's ones that are very, very bad and severe and so on and so forth. It's like briefly know it. Okay. So again, my mistake with these slides. What is this impetigo? Someone mentioned impetigo before, and differences between that and eczema. Eczema is usually diffuse on the face. This is usually common areas, is right around the mouth. Another thing is that we can describe this as honey crusted lesions. Okay, that's number one. Okay, it's very common in kids. Now, there's two types of impetigo, right? There's non-bullous and bullous. Non-bullous is caused by what bacteria? Most common.
Aureus.
Most common for non-bullous.
Pyogens.
Pyogenes. Non-bullous, pyogenes. This is in the dermatology clinical. Non-bullous. For bullous, it's Staph aureus. Both of these are very important causes of impetigo. But now identify the organisms. Which one is Staph aureus? Which one is Strep pyogenes? Staph is left, which is gram-positive cocci in clusters, and then this one is the Strep pyogenes, good, group A strep. So, diagnose and tell me what the organism is. Ecthyma, good. Ecthyma gangrenosum. Usually associated with immunosuppression, diabetes, and all these things. It's most commonly caused by Pseudomonas. Very important. Now, why is this lesion green with Pseudomonas? Good. Pyosin, pyogranin, pyoverdin, all these dyes that's produced by Pseudomonas. Good. Tell me what this first one is.
Cellulitis.
The left one. It's well defined, well demarcated. Erysipelas. The right one, can you tell that there is a line separating? Is it well demarcated? No. Cellulitis. Okay. Most common organisms for both. Staph aureus. Erysipelas is more associated with which one? Which bacteria? Strep pyogenes, okay? Both of them, they're associated with both, but that's just an extra piece of info for you guys, okay? Cellulitis, Staph aureus, very important, but it can be caused by Strep pyogenes, Erysipelas, both Staph aureus, Strep. However, it's more seen with Strep, okay? That's why it's a less severe one, because it's well demarcated, everything's. Staph aureus has an exfoliative toxin, destroys everything, okay? It just destroys. Which brings me a later image. Now, quickly with these ones, is this folliculitis, which is of the hair follicles. This one, if it goes beyond into the dermis, furuncle, good. If it goes even beyond that and starts forming and going out, carbuncle. Just I know how to identify these images. That's all I needed to know. Okay. Very important cause of folliculitis is something called bathtub folliculitis, Pseudomonas. Okay. Furuncle, carbuncle, usually caused by Staph aureus. Okay. Now this one. Staphylococcal scalded skin syndrome. Good. It's caused by Staph aureus. Now, what toxin will cause this?
Exfoliative.
Yeah, exactly. Exfoliative toxin. Perfect. Next.
Rocky Mountain spotted
Fever.
syndrome.
Good. What's the organism?
Rickettsia.
Rickettsia. What's the tick called?
The dog.
Okay. It's called a dermacenter tick. Okay. I don't know if it's in the slide, but knowing how the slides were when I looked at it, I wouldn't be surprised if it's in it. So dermacenter tick, that's a piece of information. If it's there, alhamdulillah. If it's not, forget what I just said. Anyways, they are obligate intercellular organisms, as you can see inside here. Okay. They look gram-negative, but they weakly stain gram-negative. Okay. Now over here, the most common symptoms that it cause is fever, is a rash and vasculitis. In these rashes is petechiae, okay, which is hemorrhage. Okay, and I saw on the slide, this is the only one the doctor mentioned hemorrhage in. Go with that, okay, petechiae. Usually of the palms and soles. All right, so that's rickettsia for you. Rocky Mountain spotted fever. Last couple slides, guys. What's the one all the way on the left? HSV, good. Moving on. What's the middle one in the middle? Varicella or chickenpox. Last one on the right. Zoster, good. Okay. HSV1 usually causes the oral ulcer or the cold sores. HSV2 causes what? Genital, good. Chickenpox is caused by varicella zoster. It has a vaccine now. I saw that it was emphasized. Vaccine, that's live attenuated vaccine. Herpes zoster is a complication of varicella because it remains latent. Okay, so this is also called shingles. Tamam? That's it. These are all from the same family of viruses, the herpes viruses. So they're all double-stranded viruses. Tamam? Moving on.
Molluscum.
This one, exactly. Molluscum contagiosum. Okay, this left one. Good, you got the right one. Molluscum contagiosum is caused by what virus? Or was it mentioned? If it wasn't mentioned, then forget. Just know that this is molluscum. Okay, it's a pox virus. That's what it's called. The key description of this is that there's a central umbilication. Okay, you can see in the center of it, there's an umbilication that's happening. Okay, it's caused by pox virus. The right one, you guys already mentioned, is parvovirus B19. It's also what we call a if I remember, a slap cheek. Yes, exactly, slap cheek. Okay, and it's parvovirus B19. If someone has sickle cell anemia, what complication can happen with them? Parvovirus. What can it cause? Aplastic anemia. Okay, that's something about this. It's also called erythema infectiosum. There's 5 or 6 pediatric diseases. 1 is measles, 2 is rubella. I think this was the 5th one. Okay, so you know them. Okay, specifically the ones I put images for because the other ones don't really have one. And then measles rash is not really that specific. Rubella does have a characteristic rash appearance. Okay, 2 is scarlet and 3 is rubella. Okay, thank you. Scarlet fever causes what on the tongue?
Strawberry tongue.
Strawberry tongue, good. And it's caused by what infection? Strep pyogenes, okay? It's caused by strep pyogenes, good. Tamam. Now, tinea. I'm gonna just quickly go through this. I didn't see that it was as emphasized to know the morphology because they said, I saw in the transcript that it was mentioned to skip morphology. So I skipped it, but I'm gonna put it here just very in case. What is tinea caused by? What is the class of fungi?
Mold.
Okay, more detail.
Dermatophyte.
Dermatophytes. What are the three dermatophytes? Microsporum, trichophyton, one more. Epidermophyton. Good. So, tinea can cause many manifestations all over the body, but you need to know the names. Okay. Now, A is showing you dermatophytes, just as a general. There are specific ways to differentiate them. Don't need to know based on what the slide said. Anyways, if it's on the head, what do we call it?
Capitis.
Capitis. Cap. Okay. Another way to remember it. This one on the body. Crurus. On the groin. Corpus. Yeah. This is corpus. This is what? Crurus. Good. This one is what? Both of these together. Pedis. Good. And this one? Unguum. Or another one is onychomycosis. So it's not oncholysis, it's onychomycosis or unguum. They're different from psoriasis and here. This is a fungal infection. So, last two slides. What is this disease? Leishmaniasis. What do I call this? What's a form of leishmania that's inside these macrophages?
Amastigoid.
Amastigoids. Perfect. Good. Know them. Okay. Know these features. In terms of its rash, you have cutaneous leishmaniasis. It's caused by stuff. What's a vector for leishmania?
Sandfly.
Sandfly. Good. Last slide.
Scabies.
Scabies. Good. A key thing that happens is linear burrows, okay, which is these linear lines that happens in the hands, in the basically the creases that happens. It goes all the way. These are the linear burrows that happens in scabies. Okay, very itchy disease. Affects, like usually if someone has scabies, you need to treat a bunch of people around them because they most likely have it too. You can drop by just basically clothes, the organism itself, and so on. So, we're done. Any questions?
Thank you so much, Fawaz.
No problem.
3 hours. It's really good.
Alhamdulillah. Okay. Derma, well, that's overwhelming, but my tip is just practice questions honestly help so much, so much, so much. And if you have time to watch external videos, I would recommend Pathoma, and Robbins for questions. I recommend you watch Pathoma for Derma because it's very resourceful, and then Robbins for questions for Derma. Very good questions. Okay. So, the rest of the book, inshallah, you guys get an easy exam. Inshallah, it goes by flying colors. Know the things I mentioned very well for like OSPE purposes, very well, and I mentioned a few points. SAQ, usually they'll ask you stuff that's more writing. So, for example, listing. For example, list 4 signs of this, list 5 signs of this, list treatments. So, from your block, if I say, for example, rheumatoid, okay, there's signs of pathology. There's pathogenesis. List 4 joints that this is a sign you're seen in. Is it systemic? Yes or no? DMARDs. A lot of questions can come. So, like, think of the ones that will have a lot of listing involved in it. Okay, so psoriasis, for example, even dermatomyositis, for example, list the 4 signs of that you might see in dermatomyositis. List the antibodies present in this. This is like you get these questions. They're like systems. So if you have any questions, you have my number, well, in the beginning, and feel free to ask anything. All right. Yalla, good luck, guys.